Hmm? Hmm. Hmm. आगे चलो. Good afternoon to everyone. Hello, Dr. Corrado.
Okay. Good morning for me.
Good afternoon
for you.
Yeah, I said good afternoon here. How is it, Italy, going on?
I suppose we can start in a couple of minutes.
I think we must start our webinar. It's okay for everyone?
Yep,
Yes?
Yes.
Okay. So, on behalf of Neurotrauma Committee AA SNS, I welcome all the esteemed speakers in this webinar and attendees as well. Today we have 6 speakers, me from India, Dr. Corrado Lacerno from Italy, Dr. Costas Fontes from Greece, Dr. Jay Prashant from Singapore, Dr. Harry B from UK, and Dr. Rosenthal from Israel. And I want to give thanks Dr. Corrado for coordinating this webinar in very planned way. I'm happy to share that more than 53 countries registration we received, and we have about 350 registration for this webinar. I think this is a good amount in this era of lot of webinars are going on. So this webinar will be telecast on the Zoom, YouTube, and Neurosurgical TV and WeChat. And I'm thanks to Dr. Linzu for managing the telecast on WeChat. I want to thank my moderator. We have 2 moderators, Dr. Amit Chakravarti and Dr. Gaurav Jain. They are the senior neurosurgeon in my city, Jaipur, India. And in this webinar, each speaker will be given 20 minutes for presentation and discussion. We have divided in two parts. After three speakers, we will have a discussion, and again will have discussion after last speaker. And in this webinar, we have a good number of registration of young neurosurgeons and trainees. So I wish we will have a good discussion and in this very important webinar on neurosurgical subject. So now I can request Dr. Amit Chakravarti to start and moderate the session. Dr. Amit Chakravarti is a senior neurosurgeon in my city, Jaipur. He is ex-member of WFNS Neuro Rehabilitation and Reconstructive Surgery Committee, and he is also faculty of AASNS, and he is treasurer of our National Trauma Society of India and secretary of Neurotrauma Society of our city. Now to Dr. Amit Chakravarti. Dr. Amit Chakravarti, please.
Thank you, Professor Sinha, for such a nice and crisp introduction to the webinar and me. It is extremely heartening to see all these stalwarts gathering again for another feast of academics today. And the theme of today's webinar is cranioplasty. And we have, as Professor Sinha has already told, we have divided the session into two parts, 3 speakers each, 20 minutes each speaker. After three speakers, we will have a question answer session. And I am happy to share the moderation with Professor Gaurav Jain, my colleague in Jaipur. So coming to the first speaker of the day, Professor V.D. Sinha. Professor V.D. Sinha is a senior professor in Department of Neurosurgery, SMS Medical College, India, Jaipur. He is the chairman of AASNS Neurotrauma Committee, ex-chairman WFNS Neuro Rehabilitation and Reconstruction Neurosurgery Committee. He is member of WFNS Neurotrauma Committee, executive member of ACNS, corresponding member of EMN, ex-president of National Skull-Base Society of India, ex-president Neurotrauma Society of India. He's the honorary secretary of Neuro Club Jaipur and the president of Neurotrauma Society Jaipur. Today, he would be sharing his experiences, vast experience on 3D cranioplasty in limited resource environment. Over to you, Professor V.D. Sinha.
Thank you, Amit, for introduction. Now, I think it's okay. Everybody can see and listen me. Okay. So today my topic of presentation is 3D cranioplasty in limited resources and environment. And as I told that we have trainees and young neurosurgeons for this webinar, so I have covered the basics of cranioplasty as well. If we see the history of cranioplasty, the defect repair is not a new surgery. It was started in 1565 by Petronius by using the gold plate. Then after number of bones were used to repair this. Even the outer table of skull first time used by Muller in 1890. Then after era of metal came where aluminum, platinum and titanium was started for repair, and methyl methacrylate, which we use in the 3D technique most of the patient, was started by Cled Smith in 1940. If we see the causes of cranial defect, there can be trauma, decompressive craniectomy, infection, cranio reconstruction complication, neoplasm, and number of congenital anomalies. Other indications: aesthetic, protective, and discomfort. In protective, patient very prone for seizure and sports and army persons, and shrunken skin flap syndrome. As per the Grant and Norcross, very severe headache syndrome of Trifine, epilepsy for the defect, danger of trauma, and cosmetic. We all know the syndrome of Trifine was first coined by Yamura and Meccano in 1977 after the craniotomy defect, decompressive craniotomy defect, where after this defect we see this type of CT scan finding, which cause cognitive dysfunction, hemiparesis, and sometimes hydrocephalus. And usually, most of the neurological defects recover after the cranioplasty. So we now don't do the cranioplasty if defect is less than 2 centimeter and defect is below the temporalis or occipital muscle, and usually below the 6th year of the age. Contraindications are also there: infection, immune compromised state, hydrocephalus, edema, and associated comorbidities. We all know that the decompressive craniotomy outcome has improved after the 4th edition of Brain Trauma Foundation, where fixed size of the decompressive craniotomy was there. But we don't have any guidelines for post-operative cranioplasty for timing, material, and complication. So with efforts of Professor Corrado Locarno, he managed excellent meeting in Naples, Italy, and consensus were made. And I think everybody should read this article, which help in planning of the decompressive, cranioplasty. So as far as the timing of reconstruction is concerned, it all depends on individual condition of the patient. But previous assumption was that if done after 2 months, the results are better. But nowadays, early replacement is better for better recovery and loss hospital stay. Timing of cranioplasty in our department, we do 2 to 6 months after compound wound, 1 year after infection or frontal sinus is opened, 3 months with autograft as per age or material used, and immediately for the benign tumor where calvarium surgery is done. So cranioplasty can be done by the autologous graft and alloplastic material. Autologous grafts, they have a problem in precision and durability, but osseointegration, growth potential, donor mobility, and cost factor is favorable. But when we use the alloplast, the precision and durability is good, but these factor, osseointegration, growth potential, and price is very high, which is especially not good for the LMIC's countries. As for the graft, in adult non-vascularized graft, we can use the split cerebellia, rib, iliac crest, tibia. Vascularized graft we can take from the scapula, rib, iliac crest, but in children they can have problem in a split graft. The flow is very small, so it's difficult task. Iliac crest can cause growth disturbance. Rib can cause the asymmetry of the chest. And for vascular graft, it's difficult because we need expert microsurgical skill. In pediatric cranioplasty, we know the children have unique physiology, developing anatomy, and growth dynamics. So the autogenous cranial graft is a gold standard, but it should not be done below the 8 year. And exchange cranioplasty is good because high osteogenic potential. As far as the preservation of bone flap is concerned, cryopreservation is very good, which is very common in US, but it requires storage facility and geographical transport of patient and logistic for the transfer also. Installation we can do by freezing and irradiation and sterilization. In our, when I was the trainer, then we used to autoclave the graft, but it caused devitalization of the bone, so it should not be done. So reabsorption is a very big problem of which is a very high in 50% cases, 50% in pediatric and 6.5% in adults. As far as the subcutaneous storage is concerned, it is very good place where it is osteocytes are nourished I have a good environment and no problem, but chances of bone resorption and infection is very high. And small children, they have very less anatomical place, and even in adults, they feel discomfort if this place in the thigh or abdomen. So this just to share one to experience, and Dr. Rosenthal will tell about more about this reabsorption. This was done after 6 months, so there is a always bone defect if we keep in the abdomen. Extensionoplasty is a good, but as I told in children, it's difficult, but osseointegration is good. Vascularized flap we can use the rib, latissimus dorsi, scapula, and usually indicated where there is history of radiation, infection, and scar tissue, and there. But the osteogenesis can be improved by 2-BMP protein, but we don't have. This is in literature only. Other material is ceramics, hydroxyapatite, which is very good material available in any amount, and its chemical composition is similar to the bone, has a potential of post fracture self repair. Osteointegration is 60 to 80%. It should not be used near the paranasal sinuses, and there is no reaction except sometimes delayed immune mediated inflammatory reactions are there. Other material is CCPP, which has greater compressive and tensile strength than hydroxyapatite, but it causes microfragmentation of material because the crystallization is not always the problem because of dural pulsation, and it tied very tightly with the surrounding bone. So if by any way, if you want to remove it, it's very difficult task. Titanium, we know that it has a advantage of cosmetic, very good mechanical strength, low infection rate, biocompatibility, but disadvantage are heat conduction, radio opacity, and by nowadays the use of CAD and CAM method has made a lot of changes use of the titanium implant. So plastic are another material which can be used. The disadvantage is seizure, post-operative implant, exposure, and seroma formation. Advantage is they are not osteoconductive, they are strong, but they have a lot of pores, so sometimes that soft tissue grows inside and it's very difficult to remove for any cause if you want to remove after surgery. So what is the ideal implant for the cranioplasty? It should be malleable, sterilized easily, light-weighted, MRI compatible, and non-carcinogenic. But search of literature shows no existence. So we reviewed the literature, and Professor Lecron also mentioned in his publication, there is no perfect prosthetic material for cranioplasty which is free of the complications. So we use a customized this MAPA with 3D implant, and customized cranioplasty PAMA implant using 3D printing technique we are using, and here we use the PAMA. Why we use the PAMA? Because it is inert, minimum reaction, tight adherence, MRI compatible, and strength is comparable to the bone. And this is very useful in our setup where patient cannot afford the very high synthetic implants. So customized 3D plant, why we use this technique? Because cost advantage, greater aesthetic result, reduce operating time, and biocompatibility. And we can use for more patient number of the patient. If we prepare the hydroxyapatite during surgery, it causes exothermia. It is solidified within 20 minutes, and the monomer, if absorbed in the dural vessel, it can cause hypotension, hypoxia, even death are reported. So this disadvantage is not there. So we developed 3D model by using high resolution 1 millimeter cut spiral CT scan, and it can be used for unilateral and bilateral defects both. The aim of prefabricated implant to study and plan surgery with greater possibility of achieving the expected result, and both the aesthetic and functional outcome of implant is good. And as I told, because of low cost, it can be used for more number of the patient. And further, it decreased time of surgery, and before surgery, we can do the counseling with the patient about the surgical procedure. So prefabricated implant mold using 3D dimensional printer and permacasting we are using, and we have a good results. These are our published results, and all the images DICOM we convert to the STL format, and the STL format images we send to our printing workstation, where with the help of ABS and polylactic acid they make the mold. This is the implant, and this is the mold, and this we have fixed. Now, just I want to tell that when we were using the preparing the implant during surgery, it was usually rough, irregular, and there was no precise approximation here. So there were a lot of cosmetic problems. So we started this 3D printing technique. This is the skin flap is raised. This is our mold which used for implant formation. This is our implant. This is our refreshing of the implant, and this we have made finally and fixed it here. See, very good outcome, cosmetic outcome in this patient. Large defect and very good cosmetic outcome. Just want to share this small video. Patient was operated for decompensating cranectomy. There is a large defect, and this is raising of the skin. The most important is we must raise this temporis muscle from the dura. Otherwise, post-operatively, patient can have hollow in the temporal region. So this is our mold, and this is a PAMA we are preparing to put inside this, and this is we have put inside. Generally, it gets stick over the mold. So we put either bone wax or saline. So when we remove, it doesn't break or it removed easily. So this we are doing. This we have taken out. So sometimes it get, I told, stick. So we put bone wax. So it comes out easily without any problem. So this is the refreshing of the edges. This is prepared, and now we can fix it. This is we have fixed it. So this is another video. The patient was operated for decompensating cranectomy. It was large defect. See, very large defect, and this is the mold. This we are preparing, and see, very good approximation of the margins and smooth surface, and very good approximation and good cosmetic outcome of the patient. This is another patient, very large defect, and this is a post-operative. This is the pre-operative and post-op, very good cosmetic outcome even in children. Nowadays, cranial defect prints out are we keep. So before putting over patient, fixing over the patient, we check it here. So it gives more or better precise approximation of the margin. And nowadays, again, we are not preparing this implant in OT. It comes out from factory. So it further reduces our operating time. Even in the difficult situation like this, frontal region, very difficult to give good cosmetic outcome. This technique has made very good cosmetic outcome in the patient. Very good fixation is there. Even in children, very good cosmetic and outcome of the patients. It's complications as infection, granuloma, skin erosion, they are usual complications. And migration, so if there is a migration, we can refix it. If there is a hematoma, if it is more in amount, we have to then explore and evacuate the hematoma. So round about till now we have done in 64 cases this with this technique. And this is video I want to share showing the pre and post of cosmetic outcome of the patient. See, very large defect, very good outcome. This patient already been shown. And very large defect. And this incidence of cranioplasty is increasing in our country because of more road traffic accident. Patients are not following, low people are not following the road traffic rules. Very large defect. Even in bilateral, is a very good outcome in the frontal region. Very large defect, even in any age, any condition of the patient, even in comorbid condition, we can use it for improving the neurological deficit. Even in children, as I told before, very good outcome. So just I want to conclude my presentation by saying that it is a precise compliance of prosthesis to osseous defect was achieved, and we have 2-year follow-up in most of the patients, but recently we have done few, we don't have follow-up, but the results are very aesthetic changes with very significant, they are very significant and satisfactory. And the important thing is patient investing only $300 including the cost of implant, which is very economical for our countries or low income countries. And titanium we do, but very few patients can afford it. So we have zero infection rate because we do as a first case by senior neurosurgeon, and surgery duration is less, and we always calculate the approximate period between the cranectomy and cranioplasty. And we have very economical this our cranioplasty. And thank you with this. Yes.
Thank you. Thank you, Professor Sinha, for such a nice talk and introducing us to such low-cost innovations in cranioplasty. Really appreciate your talk. We would love to have some question and answer session with you subsequently. Moving forward with our next speaker of the day, Professor Corrado Lacarino. He is Associate Professor in Neurosurgery, University of Modena and Reggio Emilia, Department of Biomedical, Metabolic and Neural Sciences, University Hospital of Modena, Neurosurgery Unit, Modena, Italy. His areas of interest include not only traumatic brain injury and spinal trauma, but neuronavigation and neuroendoscopy is also his much relished areas of interest. He has a list of memberships. To name a few, he has headed the trauma group of Italian Society of Neurosurgery from 2018 to 2020. And he also was the secretary of this group from 2012 to 14 and 2016 to 2018. He is also the member of Neurotraumatology Committee of the World Federation of Neurosurgical Societies. He is member of the editorial board of the Progress in Neuroscience, which is the official journal of neurology, neuroradiology, and neurosurgery hospital society. He is member of the advisory board of Journal of Neurosurgical Sciences, and he is co-associate editors-in-chief in Surgical Neurology International Trauma Section. Today, he would be talking on cranioplasty in stroke patients. So, Professor Corrado.
Thank you very much. Thank you for your kind introduction. Let me share the screen. Okay, are you able to see?
Yes.
Okay, my topic today is the cranioplastic post-stroke. Is an interesting topic. Is well known in literature, this entity, but unfortunately are few papers that talk about the only cranioplastic following stroke. But usually the stroke patients are inside a casuistic of overall cranioplastic, and stroke represent usually the minority of the cause of decompression. And in all the reports, we can note how the number of cranioplasty due to stroke are no more than 10 per year. So as showed in this French study, as a wide nationwide study of 10 years, they report that the long-term survival is not well addressed following cranioplastic for infarction of a middle cerebral artery. But what we know about this kind of patient? About this kind of patient, we know that they have a high possibility to be reconstructed after the decompressive craniectomy, and usually are patients not so old. And this is a recent published huge German cranial reconstruction registry, and we know how ischemic stroke could be less than 1/3 of patients underwent cranioplastic. But it's very interesting to note, for example, that the modified Angle score at admission is different from the TBI and the stroke patient. And the stroke patient seems to arrive to the reconstruction worse than a TBI patient. The age also in this German registry is older for the stroke patient respect to the stroke to the TBI patient. But it is interesting to note that the stroke has a protective factor associated with a minor rate of surgical revision and respect to TBI. Maybe one of the reasons that the stroke patient arrived to the reconstruction with a better condition of brain swelling. There is less brain swelling and less refined syndrome in a stroke patient. But what is surprisingly reported is the impact of timing on cranioplastic on outcome. In this German registry with 502 patients, they demonstrate that the early cranioplastic seems to be worse than delayed cranioplastic. So the early cranioplastic seems associated with increased likelihood of surgical revision. And this is surprising because in this, my personal analysis, this is one of the few reports that report that an early cranioplasty could be worse than late. And it's interesting to know that the number of patients of this report. So we should have some consideration about this conclusion. All we know that it's very difficult to understand the real outcome of cranioplasty because the postoperative course of cranioplasty could be influenced by many events before cranioplastic, many events between decompressive craniectomy and cranioplastic, and also events before decompressive craniectomy. So it's very difficult to understand which kind of complication is directly connected with just cranioplasty. And about the outcome, how to measure the outcome after stroke, we all know this paper. This paper is the paper that showed how we can have a favorable outcome after the compressive craniectomy for stroke patient. And this patient is based on a pooled analysis among these 3 different studies. And this is one of the limits of this paper, because we all know that these three kinds of study are different in statistical analysis, surgical timing, and inclusion criteria. And another crucial point of interpretation of the data is the interpretation good outcome, favorable outcome, as a modified ranking score less than 4 or as 4. We know the modified ranking score, and 4 means a patient unable to live without assistance. And this could be enough for a young people after the compressive craniectomy. I mean, young people unable to work without assistance and to attend to own bodily needs without assistance could be a satisfactory results respect to older patient. But as the Cochrane collaboration showed, if we analyze the same paper, the same patients, and the same pooled analysis, we analyze intended as a good result, modify ranking less than 3, so the two treatment, decompress or not decompress, are the same, and we have no different. This is what, for example, we know in our series. This is the Modern and Reggio Emilia Stroke Network. We are two big hospitals. Just in Modena, we have the endovascular neuroradiologist team. So if a patient needs a neuroradiological endovascular treatment, is moved on Modena. Otherwise, in both hospital, there are a stroke unit, a neurosurgical unit, and the protocol of discharging, if the patient has less than 8 of GCS or less than 8 of GCS, could in a higher level rehabilitation center. If the patient has a higher than 8 of GCS score or less than 8 of GCS score, but just for 12 hours, the patient can be transferred to the less complex rehabilitation center. And what we observe in our experience in the last 5 years, that we manage about 1,000 strokes per year, and we performed 44 decompressive craniectomy stroke patients. Of these, 34 was decompressed and 14 dead, and we observed in 1 year of follow-up. You can note how the results are totally different if we analyze a modified ranking score less than 3 or a modified ranking score less than 4. So this is most important when we write a paper or when we want to analyze our results. About the age, is well known how the age is a strong prognostic factor also for mortality, and this is confirmed in our results. And this is a nice paper that shows clearly how the compressive craniectomy in patients older than 60 is devastating in terms of mortality. But the age is not so connected with outcome after cranioplastic. We observe how an age less than 50 years can have an impact of good outcome only when we consider good outcome less than 3 of modified ranking score. No impact on good outcome if we consider a good favorable outcome, an outcome with modified ranking score less than 4. So this is very important when we design our studies. About the NIHSS, on mortality, there is no significativity, and even on the outcome after cranioplasty, there is no statistically significant impact for this patient, for our patient. We also analyze, for example, the time of onset of stroke during the day, also the time when we perform the compressive craniectomy. But when the patient has a stroke and when we decompress the patient is not important about the mortality. What is very important about mortality, of course, is the timing of the compressive craniectomy. And we observed in our series that the compressive craniectomy performed within 48 hours from stroke is statistically significant on mortality. And this is a well-known topic and in literature. But just to understand that it is safe to treat a stroke patient early, to decompress the patient, but this impact, this timing has no impact on outcome, mortality, and complication. And also in our series, we didn't find any correlation between the compressive craniectomy timing and impact after cranioplasty. Nevertheless, in the French nationwide study, surprisingly, the early decompressive craniectomy reduced survival, but maybe the author explained that when a decompressive craniectomy is performed in early time, that means that the patient has a larger ischemic stroke. So maybe the bias of interpretation is that the worse is the patient, the earlier is the decompressive craniectomy. About the compressive sites, we all know also about the Brain Trauma Foundation, how the size of the compressive craniectomy should be at least 12 centimeters of the anteroposterior diameters, better than 15 centimeters. And we didn't find any significant result on mortality, but because, and I'm happy to observe this, the majority of the patient has a good decompressive craniectomy. And I'm happy because about 10 years ago, we published this series from the same region, 526 cases of the compressive craniectomy for all reasons, but it was said at that time that the patient underwent the compressive craniectomy with a diameter less than more than 12 centimeters is quite the half of the series. And now, after 10 years, quite all the patients are decompressed with nice sides. What just we observe in this series of 30 patients, and that the lower modified ranking score has the patient, and the smaller is the flap, even if the flap is in the range of 12 and 50 centimeters. A very interesting thing is about midline shift, because we know that a midline shift more than 10 millimeters is extremely statistically significant for mortality. Less significant, so not quite significant, is when the shift is 5 millimeters. 5 millimeters before the compressive craniectomy. That means that it's more important, it's much more important to operate the patient, to decompress the patient between 5 and 10 millimeters. And another very interesting observation about the midline shift is there is a linear correlation among time, volume of stroke, and the shift. So the more increased the stroke volume, the more it will increase the midline shift. So if we have a more huge series, we also can have we also can find some value of predictability of the stroke volume on the shift, and so on the outcome of the patient and the mortality. Unfortunately, the midline shift has no impact on the outcome of cranioplasty. So no impact if the midline shift is immediately post-operative until 15 days post the compressive craniectomy. And the GCS value is extremely significant in our series. and this event is well known in literature. And also the GCS before decompressive craniectomy is considered statistically on outcome after cranioplastic in our series. Much more interesting observation about hydrocephalus. This is our series, and the blue box means that Evan index is more than 30, and you can note how there is very few patient with Evan index more than 30 pre and post decompressive craniectomy, much more patient pre and post cranioplastic, and much more interesting that the 8 patient underwent remotion, so revision, and the revision has quite totally the Evan index more than 30, but just 2 patient has a clinical hydrocephalus that needs a VP shunt. The hydrocephalus, comparing with decompressive craniectomy to TBI and cranioplastic for TBI, hydrocephalus is not a so much more important, has a traumatic brain injury. We also analyze in our 30 patient underwent cranioplastic if there is some correlation between the distance of less than 2 centimeters between the medial border of the bone flap and the midline, as some authors advocate, but we didn't find any significant, statistically significant correlation. But anyhow, it's interesting to note that all the quite all 75% of revised patient has this distance less than 2 centimeters. So what we find as statistically significant is the hydrocephalus post cranioplastic, meaning hydrocephalus in our series just Evan index more than 30. So if the patient has an Evan index more than 30 after cranioplastic, is most probably the patient keep this value during the rest of the observation. And so it is a clear, as more than 20 years ago, Chosnica showed us with this elegant paper, just 2 sheet of papers, but he demonstrated how the patient before cranioplastic have a doesn't have a brain compliance, and after cranioplastic the brain compliance back to works, and with the restoring of CSF circulation. This is our complication, and we have 8 patients with complication. Among these, 5 patients as a septic complication. The other 3 patients, we have 1 revised patient due bone flap resorption, and 2 patients with epilepsy that dislocate the processes following trauma for epilepsy. So it's well known how the sepsis is a problem for the stroke patient and cranioplasty. But we try to find some correlation, for example, for timing, and the average of timing of cranioplasty in this series is about 5 months, but 5 months for each kind of group. So 5 months for revised and non-revised patient, and 5 months with the patient with a modified ranking score less than 3 or less than 4. So in our series, timing cranioplastic not has impact on revision rate and on outcome. So what we had observed in our series that the impact on outcome is a young age less than 50 years. The Glasgow Coma scale pre-decompressive craniectomy, and we should pay attention when we can observe and have an index more than 30 after cranioplasty. The clinical and condition and the timing doesn't affect the impact of the cranioplasty for stroke patient. So we need, of course, much more observation. This is also the conclusion of the German registry, when they observe that the stroke patient seems to be better than TBI patient, but they did understand which pathophysiological rationale are under this observation. What is interesting, also demonstrated by the French nationwide study, that the quality of the care impact on the outcome. So the French study demonstrate how the surgical activity of the center and the continuity of the activity of the center has an impact on outcome. And this is our stroke team, and the stroke team has a very connected team between neurologists, neurosurgeons, neuroradiologists, and the rehabilitation facilities. The future for understand the outcome, for example, are the advanced imaging. In last 2 years, we assist publishing about this topic when the recovery of the DTI, the demonstration that there are a recovery of imaging of DTI on the tracts reappear after cranioplastic, and this is correlated with function. So this is very important when the imaging are connected with the function of the patient. So I think that now is time for a consensus conference also on post-stroke cranioplasty. Thank you.
Thank you, Professor Corrado, for a very informative talk. And I'm sure a lot of work still has to be done regarding the timing of cranioplasty, as you mentioned in your last slide. Moving ahead, the third speaker in today's webinar, Professor Kostas N. Fontas. He is the director and chairman in Department of Neurosurgery, Faculty of Medicine, University of Thessaly, Larsia, Greece. His scientific interests are focused on functional imaging, electrophysiology, epilepsy surgery, neuro-oncology, and neurotraumatology. He has contributed more than 200 publications in peer-reviewed journals, as well as 25 chapters in textbooks. He has edited 5 neurosurgical textbooks. Today, he would be talking about hydrocephalus and cranioplasty, a challenging management. Over to you, Professor Kostas.
Great, thank you so much. I hope that you can hear me well and you can see my slides well.
Yes, yes.
Great. Okay, let me just run it back really fast. So it is indeed a great pleasure and a true privilege for me to be with you today and share some of my thoughts, some of my experience regarding the management of hydrocephalic patients, particularly during cranioplasty. And it's always a challenge to follow Corrado Iocarino, my good friend, who is a great speaker and has always an interesting topic. So with no further delay, these are my disclosures, my financial relationships, which will not affect in any way my presentation today, since I'm not going to discuss any products of these 2 companies. I live and practice in Larissa. Larissa is in the heart of the Greek mainland. And we do
Excuse me, your slides are not moving, and if you could make it to full screen, please. Sorry for the interruption.
Let me see. So, do you see my slides now? Are they moving on?
No, no. And it needs to be in full screen.
Okay. Just give me 1 second.
Yeah.
What about now?
Not yet.
Okay. You don't see my presentation moving, right?
We can see your presentation, but it is not in the presentation mode and it is not moving.
I think you have to stop share and reshare again.
Okay, yeah, let me just do that. Okay. It's not moving now.
If you could go to the previous slide on disclosure.
I'll stop again.
Mhm.
Okay. So now you can see my presentation on full screen, can you?
Unfortunately, no.
Okay, I assume that I have to stop and maybe move to the next speaker and see how I can solve that and come back. What about that?
Yeah, fine.
Okay, all right. I apologize for that, but
Costas, try to go out and to go in once again. Usually it works.
Okay, let me just try it.
Yeah, I think we can wait for a minute if you could manage it.
So can you see it now?
Can you keep on
No, I
presenter
mean,
mode?
Costas, I mean to go out from Zoom connection, close
Okay,
Zoom connection and restart once again with the same link.
Corrado, I think that it will be better to just move to the next speaker, so I will not delay the whole
Yes, we
webinar.
can move
And
next
then
speakers, yes.
Yeah, I can reconnect. Thank you. I apologize.
Fine. So if you could stop sharing, Professor. Yeah. So we would be coming back to Professor Fontas subsequently because of some technical problems. Moving ahead with the next speaker of the day, we have Professor Jay Prashant Rao. He is consultant neurosurgery at National Neuroscience Institute, Singapore. Dr. Jay Prashant Rao is a senior consultant neurosurgeon in the National Neuroscience Institute. Dr. Rao is also extensively involved in the education of neurosurgical residents and is the program director for the Singapore Integrated Neurosurgery Program. Dr. Rao is also the director of the NNI Head Injury and Trauma Program and is involved in optimizing the care of neurotrauma patients in the institutional and national level. Today, he would be talking on cranial reconstruction and unmet need and pitfalls. Professor Rao, over to you, please.
Thank you, Prof. Sina and your team for inviting me here today. You should be able to see my slides
Yes.
at the moment, right?
Yes. Yes.
So once again, thank you for for giving me the opportunity to speak here. So I noticed quite a distinguished list of speakers. So I thought I would focus a little bit more on maybe some of the junior neurosurgeons who may be here and those who are in training to consider about aspects that what do patients need and the pitfalls associated with certain areas of decision making. So in terms of disclosures, I don't have any disclosures to announce. I want you to just think about when we talk about the themes of the cranioplasty and what I'm going to be speaking about. We did have some discussion in terms of timing of cranioplasty, types of materials, complications, and some elements of what the future landscape should be like. Over the years, I would say last 15, 20 years, these topics have been coming up all the time. And we've been revisiting them in neurosurgery quite often. And we never really come to any sort of consensus. And I believe some of that difficulty is the fact that we all practice in very different regions. So when I first became a consultant in 2013, 2014, actually, I went through the literature at that time, trying to come up for myself what would be the ideal sort of scenario if I'm doing cranioplasties and in the long term looking after neurotrauma type of patients. So when I looked at it, I realized there was an unmet need, specifically in Singapore. So in our local context, one of the problems that we had was that we did have a calvarial bone bank. And that calvarial bone bank, one of the advantages in Singapore is as a high income country, we do have access to resources. So what we would put back the skull bone, so we don't put it in the abdominal pouch. We actually store it in the bone bank, take it out, autoclave it, and put it back. So there were needs because patient bone resorption. But the problem for us became that we had an American audit that came in. And the American audit looked through our process of sterilization and things like that, and raised a lot of comments about how we audit the right bone going to the right patient and things like that. And it became very cumbersome and expensive to do it that way. So we shifted totally away from allografts to now using implant materials. And at that period of time, cost was an issue. Our insurance in Singapore didn't pay for the implants, but thankfully we have sorted that out now, and our implants are covered by our government insurance as well as private insurance, right? So the need then became a clinical need, no longer a financial related statement. And the clinical need was, how do we get patients out of the hospital as best as we can in the best functional status, right? So I would say the aims of cranioplasty are basically protection first, right? We want to restore the hydrodynamic status of the brain. The brain is supposed to float in CSF, right? And this is what I mean about the hydrodynamic status of it. And how that CSF functions around is going to be affected when the cranial vault is not full. Then there is an element of cosmesis, and I don't think we should look down on this. Patients have a lot of quality of life issues when they look different from what they are supposed to be looking like when they look in the mirror. And then there's this question of improvement of neurological deficit. Now, this is a hard question to answer. The reason it's a hard question to answer is because it is very patient-specific neurological deficit. A stroke deficit is going to be very different from a TBI deficit. And this is where you need a real good rehab physician to work with you, which we are very fortunate in Singapore to have. So they're the ones that pick up the subtle differences that from the first month I send them to rehab, over the period of 6 weeks, they notice the gait instability getting worse. Subtle signs, you don't get all the way to trephination. I've had cooks where they lose fluency of their hand and they can't cut as fast, right? And those ones nowadays, I bring their cranioplasty early, all right? So if you know your aims, if you graduated, you're working, you want to know your aims, then you start deciding, when can I do cranioplasty? To me, actually, the answer is is out there already. Based on a time when I graduated out, this was a paper that came out, and I looked at it, and the definition of early was a bit difficult for me to understand, right? In Singapore, our patients stay in the hospital, go home, and come back very easily. We don't lose to follow up because Singapore is a very small country. So I see people 3 years, 4 years after decompression as well, and then change their mind and want to do cranioplasty. We don't tend to lose them compared to the large centers, right? But what I notice is even in the hospital system, because of our level of care, we don't have so many infective issues in terms of the wound, right? And because of that, there is an option to do what I would consider ultra early cranioplasty. And when I say ultra early, I mean 4 to 6 weeks, right? I do the cranioplasty while they're inpatient. They go to rehab, they come back for cranioplasty and go back to rehab. And there are a specific group of patients mostly related to the traumatic brain injuries that benefit the most from this, right? So in my practice, there's a gradation. I would say early is from 4 to 8 weeks, right? And late is anything from 8 weeks onwards, up to about 6 months. I think beyond 6 months, most of the cranial recovery is very hard to prove, right? There is some recovery that happens very late, but the latent recovery happens early. So if you look at the box plot in this diagram in terms of your rehab improvement scales, they all tend to happen mostly early. You will have some late improvement, right? But generally speaking, I think if you can reform the calvarial wall together with the hydrodynamic status of the brain, that gives the patient the best starting off point to get their rehab and progress on from there. Obviously, this is a heterogeneous condition. In Singapore, we decompress for mostly hemorrhagic strokes as well as trauma. Our ischemic strokes, not so many because we get quite good early RTPA treatment, as well as now with our neurovascular colleagues and endovascular colleagues doing clot retrieval, our stroke outcomes have improved quite markedly, right? So in terms of materials, when I looked at the materials, there's a whole range of materials. There's autologous bone, titanium, PEEK, hydroxyapatite, methyl methacrylate. And this is one of the problems. You have to decide yourself, what are you going to use, right? Too much options are actually bad for surgeons because we tend to jump from one material to the next, and we tend to make decisions based on our last case. Oh, I used titanium the last time, and because of that, I had an infection. I will never use titanium again, right? So I think you have to apply a little bit of science behind it. So in this paper in 2011, there was a statement made about what do we actually want when we do cranioplasties, right? We want to achieve cosmesis. Ideally, our material is resistant to infection and is resistant to temperature changes in patients that live in markedly changing hot and cold temperatures, right? And it is strong, but also easy to shape. And I think the key one that we really need to look at now is in terms of radiolucency, is compatibility with MRI, right? A lot of titanium material, when you put in MRI now, actually obscures our reading of the brain because of the metal artifact. And we're paying for it now. Some of the materials that we put in 10 years ago, patients are coming in with stroke, coming in with other neurological conditions, dementia. I want to MRI them and I'm losing half the hemisphere, right? So these are some of the things that sort of leads me away from some of the titanium, but it is a very good, strong material. So in the Singapore experience this is probably early 2000s to mid 2000s, we were predominantly putting in PEEK and titanium mesh. So this is not preformed titanium, these are titanium mesh. And actually we had very high failure rates, you know, and the failure rate was not really only due to infection. The titanium cranioplasty mesh was extruding through the skin. So this resulted in implant failure. So if you look at our Kaplan-Meier graph, essentially PEEK had a very strong early failure rate, right? And that early failure rate was mostly due to implanted infections. So Staph aureus was the number one bug in terms of the infection. But after you get past 6 months, it lasts, right? We had no issues with extrusion, but our titanium implants all had extrusion failures. And each year we would see more and more coming back. And since then, we have moved away from the titanium mesh. So what do I use? I actually only use two materials because I'm very familiar with them. I use PEEK, polyether ether ketone, and I use a porous titanium material that is 3D printed. And this is made by Materialize for me, right? You will notice that I have dural tenting sutures. I always tent. I tell everybody it is the best thing and the simplest thing to do, right? So the PEEK itself, I anchor with my titanium plates and screws. The actual titanium mesh actually has a preformed hole for you to anchor. The difference between the two, there's only one difference when I decide material, and that is in terms of strength. So if it is a young patient wants to go back to high strenuous activity, fall from heights kind of thing, does rock climbing and things like that, I will put in the titanium, right? And that is purely because I have seen PEEK failures with falls, right? The PEEK material doesn't break, but the implant can actually lift off when the titanium plates and screws break, right? So others in Singapore also use PEEK, and this is the example of the mesh that we used to use. Very terrible. I would highly recommend nobody ever use this kind of mesh again. Very bad for the skin and usually very high failure rate. So in terms of the complications that we see, I'm going to show you just some challenging complications that you need to consider. I know Prof. Gee is going to give us a talk on bone flap resorptions, and you've heard about infection risks. And then the actual complication risks have never really been defined when papers report them. People tend to report different complication rates because they are looking for different things. So some people definitely extradurals, intracerebral hemorrhages, wound breakdowns, these are definite complications. Some people would consider seizures to be, does the patient already have scar epilepsy? Is the seizure really related to the cranioplasty or not? But what we do know is the elderly and poorer GOS and bifrontal cranioplasties are the ones that are real challenging, right? In Singapore, our population has aged quite rapidly over the last 20 years. And I will tell you, the elderly in our Singapore still get cranioplasties. I do cranioplasties in 70-year-olds, right? And that's because their skin quality is good, right? I find age not to be the cutoff. The cutoff is actually the quality of the skin, right? And their functional status after they have suffered their injury. So I've done a bifrontal cranioplasty in a 65-year-old, right? And it's fine. So we shouldn't use absolutes. We look at the patient characteristic. So in terms of infections, like I said, the rate of complications when people report over the years, very hard for us to understand, and that is why we get this huge range of complications. What I would encourage everyone to do is to have your own internal database and look at your own complications as they occur and look at, are they reasonably preventable or not? Okay. So there are problems with these titanium mesh because they can fracture, right? So patients can fall on it and the mesh can fracture. I recently had to take out one that was put in about 15 years ago. And you can see the shape, the head shape is not cosmetic at all. It's a flat head. The mesh, the bone had grown around the edges of the mesh. And when I lifted the mesh off, actually the mesh breaks without me doing anything. So actually, if something had dropped on this guy's head, the whole mesh would fracture. So there's no protection afforded by this mesh. I actually had to drill out the bone to peel off all the pieces of the mesh to leave nothing behind, right? After you have peeled off the whole mesh, right, you can see the imprint on the brain. Okay, so there's a very small CSF tear here, which I repair usually with a muscle patch, right? I primarily repair all CSF leaks. I do not use Duragen or anything. I will harvest pericranium or take a muscle patch and I'll patch it up and I'll reinforce it with usually a fibrin sealant, right? And now you can see when we put the PEEK implant across, the shape recreates, right? And this guy has a very good quality of skin. You can see his skin quality is very thick. So just actually undermining the skin and pulling it across, it closes very easily. So no problems at all. So methyl methacrylate, I've seen fractures of it before. We have put in before because of cost issues. Patients couldn't afford the implant. Patient fell down, and unfortunately, the implant, when it fractures, causes a lot of brain contusions, right? The damage caused by it actually can be quite significant. And that is why I think in terms of materials, you have to look at what is reasonable for your location and also how you counsel patients about what you're supposed to be looking out for. This is a PEEK implant, and you can see the scalp view I put here. This is a short video. I hope it plays okay due to the bandwidth. But if you see the implant, after a seizure, this implant has now resulted in a lift off from the edge. There's a big gap here, right? So the patient actually had a GTC and fell down. Because of that, couldn't protect his head. The mistake in this PEEK was done in another center in Singapore. But if you look at the anchoring plates are all posterior. There's no frontal anchoring plate. So the minute this patient falls down, hits his head, the whole plate will lift off and the screws will lift off, right? So the PEEK will not break, but I had to reopen this and re-anchor the whole thing. Out of the 4 plates and screws you see here, only 1 plate was working. All the other 3 had come off. So even in terms of the implant, how you anchor and secure is important. So these are some of the things that we tell patients. If you fall, hit your head, you do need to get a scan because your plate can actually fracture even though the implant is strong, right? Another, I was hoping to follow after the hydrocephalus talk so that we knew about shunts and cranioplasties, but if you look at some patients, they always do develop a hydrocephalus problem post decompression. And historically, what we used to do is we used to shunt them early, right? We used to shunt them early in the worry that there's going to be cranial worsening. And once you shunt them early, to do your cranioplasty is very difficult because you're going to end up with this situation where you have a huge space cavity, right? And what is the risk of extradural hemorrhage? What is the risk of this collection getting infected? And then what you have to do is you either have to tie off the shunt, or in Singapore, we use programmable shunts. So we're lucky, we can turn the shunts up, right? But even turning the shunt up, after 2 weeks of turning the shunt up, there's still a significant collection, right? And there's no real improvement in the patient's condition, pre-cranioplasty and post-cranioplasty. Right? For this to fill up in time took about 6 months, right? Because I was not willing to tie off the shunt. I was a little bit worried that if I tie off the shunt, there could be an acute decompensation of the patient while outside the hospital. And I can't keep him in the hospital for that long period of time. So sometimes you have to make a compromise. You put your implant, you monitor, you end up with a lot of scans. And this is the problem I find with shunting and doing cranioplasty. So what I tend to do nowadays is if I look at the ventricles and the ventricles are getting bigger, I actually make my implant. I have it ready. And then I will put it in and I will put in an external ventricular drain. And then only after I've assessed the cranioplasty, I wean off the EVD and I decide, does the patient need a shunt? Because I find this to be the safest way to balance the needs for shunt versus no shunt. Some people I know will cranioplasty and shunt at the same setting. I find the risks of that to be too high. and I prefer to stage. So I will cranioplasty first and shunt second, preferentially, right? And so far it has worked for me. I haven't had much issues dealing with complications due to that. But like I said, Singapore is a high resource area. We're allowed the ability to do these kind of interventions. So if we go on to where I think we should be moving as I end this talk, is that we know there are always going to be individual complications for surgeons. It's very hard to go back into the literature and compare Germany, France, Singapore, India, Japan. Circumstances are very different, right? But I think the key thing that people should focus on in terms of research is actually tissue engineering, right? So when I talk about tissue engineering, I'm not talking about the implant materials anymore. I'm talking about what are we going to layer over the dura that will provide some biomechanical strength, as well as give you the ability to activate it to become an artificial cranioplasty. So this is my aspirational goal, things that I work with engineers for. This is materials engineering, where you have to look at whether you could actually put in something that wouldn't have you to reopen the skin, to go back in and do your cranioplasty. And if you need to, what can you do to augment skin coverage? Not so much artificial skin, but actually how do you make the skin thicker, right? So remember, you're always in a continuum of care in TBI. So from my perspective, comprehensive management of the individual patient is key. And this is done in a tertiary hospital, right? So if you can do your cranioplasty early, if you can get your infection rates really controlled through a good protocol, I think it's best to do early. And I would advocate 4 to 6 weeks, right? Out of the 90 consecutive cranioplasties I've had, I've only had to remove one for infection, and it was an implant infection. It was a staph epidermis, right? So I took it out. 3 months later, I put it back in, and the patient's okay so far, right? So these are my references, and thank you for your time today.
Thank you, Professor Rao. I really appreciated your presentation. It was not just informative, you summarized things quite well, and the most of the pitfalls and the problems we encounter post cranioplasty you have tackled excellently. Coming over to the question answer session, since we have finished 3 talks of the day, there are a few questions for each of the speakers. So the first question for Professor Sinha, we have a question from Dr. Utkarsh Bhagat. His first question is, when to do cranioplasty after resection of malignant calvarial tumor and the choice of material?
Yeah, I think this is very important issue, but truly speaking, we have never done cranioplasty after the resection of malignant brain tumor. So I don't have much experience.
Thank you. And the next question is, what is the recommended technique for fixing cranioplasty in pediatric patients, especially those who are less than 6 years of age? Do you prefer sutures or titanium screws?
I prefer this suture rather than screw, because this is a growing skull. So I prefer the this suture for fixation of the implant, number one. Sometimes what literature also says, we can put the hydroxyapatite over the margins. So if there is a growth, it will cover the defect and give a strengthening to the space.
Thank you. Thank you, Professor Sinha. Another very interesting question, that what are the predictors of sepsis in cranioplasty in post-traumatic craniectomy? And can we do cranioplasty in presence of any infection in the body, like chest or in the body? So this question, maybe Dr. Rao, if you are able to share your experience.
So I think chest infections and things are not a good idea to be doing cranioplasty because you're going to submit the patient at least to another general anesthetic. You only make things worse. Generally speaking, I would say, one, look at the skin condition, make sure the skin condition is good, and then look at the systemic profile of the patient. Nutritional status is also important. It's one of the things that we tend to not look at properly. So if you can get the nutritional status good, make sure there's no infection on board anywhere, and the local skin quality is good, then I think these are the optimal factors that you need.
Fine, thank you. We have a question from Professor Dhaval Shukla, Nimhans, Bangalore, India. This question is for Professor Corrado. Sir, what is your opinion on decompressive craniectomy and then cranioplasty in patients with cerebral venous sinus thrombosis? Because usually the brain bulges for a few months. So the strategy for timing of cranioplasty, should it change in such cases?
Thank you for your question. And as I answer in the chat box, maybe one of the reasons that this is a time of consensus conference is proper for some question like this, because due to the number of patients, we have the right answer. What I can consider is, as in traumatic brain injury, we should avoid as much as possible to reconstruct the patient when we have a brain bulging. So it depends on the possibility to treat this bulging brain. And if you have a need to reconstruct the patient, so you have to reconstruct the patient, maybe you can also try to reconstruct the patient. There is some kind of loose cranioplasty if you need to reconstruct the patient. The main problem, as Professor Rao demonstrated, is the indication, is to consider why to reconstruct the patient. The bulging for sinus thrombosis is not due to the absence of bone flap, and so this is the reason, because we have to understand when we have to reconstruct this patient. While there is other kind of patient when the brain bulging is due to the absence of the bone flap, and so we have to try to reconstruct the patient that before. And let me say another comment about sepsis. Let me add a comment to Professor Rao, that we should pay attention to distinguish sepsis from colonization. And so in the consensus conference on post-traumatic cranioplastic, we stated that the colonization of the patient is not a contraindication for cranioplastic. So we do not have confusing terms. Sepsis means fever, means leukocytosis, means not wound healing, and that's sepsis. And there is a contraindication for reconstruction. Colonization, how we can observe in the majority of patients when they are when they stay long time in ICU or long time in rehabilitation facilities, that patient can be reconstructed.
Fine. Another question for you, Professor Corrado. Dr. Hitesh Kumar, he wants to know that in this era of so many implants and so many materials for implants, should surgeons make all kinds of attempt to preserve the autologous bone graft in the abdominal pouch or like that? Or
yes, look at this is a question depending on the regional areas. For example, in Italy, it is forbidden to store the bone in the abdominal pouch. So in Italy, as in much more country in Europe, we have to store the tissues in bank tissues. So you can consider bank tissues. Each regional bone tissue has decide, but we cannot store the bone tissues in the body. So the consensus conference on cranioplasty stated that autologous bone is the first choice. And so we have to try to use the autologous bone as much as possible. Even if autologous bone has a higher rate of complication, higher, not high, higher rate of complication, because autologous bone is the only material that can be have a bone flap resorption. And so there is a huge meta-analysis of 1 year, 2 years ago published, and where the bone flap resorption is reported up to 20%. So you can imagine if you can propose a alloplastic material with the 20% of complication, there is no way to have a success of that material. But anyhow, due to biomimetic characteristic and biological characteristic, we have to try to use the bone, autologous bone before.
Okay. Thank you, Professor Corrado. Professor Rao, there is, as you told in your presentation, that you usually do cranioplasty and then followed by ventricular shunt if needed. But if at all the ventricles are dilated, you prefer to put an EVD. So for how many days you prefer to keep the EVD?
So I think we are very fortunate in Singapore because I can get an implant. The fastest company that we have in Singapore actually comes from China-made Peak. So they have a very large factory. They can deliver to Singapore within 3 days from when I send them the scan. In-house in Singapore, actually, we are developing capability to 3D print cranioplasties as well to use. So I think the duration of the EVD now is not really a question. Yeah, you base on the clinical need of the patient, right? So I think nowadays we're getting a lot of techniques where you can do cranioplasty early. The question is, do you believe the infection rate and complications associated with the early cranioplasty, right? And I think that one is actually region dependent and how they go about doing their cranioplasty.
Fine. Another thing which you mentioned, and Dr. Manoj wants to have a question regarding this, is what are the chances of seizure apart from scar epilepsy post cranioplasty? What are the major reasons of seizures post cranioplasty?
So that's a very good question. I think a lot of people have struggled with this. The only patients that have had seizures after cranioplasty are post MCA infarcts, right? So large cortical area involvement that we go to do a cranioplasty, and because you are raising your flap over a large area of the cortex, I think that trends towards more seizure activity. So I only give seizure prophylaxis in patients who are MCA decompressions. The other patients, I do not give seizure prophylaxis when I operate.
Fine. Yeah.
Can I ask Dr. Rao, what is your experience for cranioplasty in malignant tumors? Because I don't have experience.
Ours is very rare as well. Mainly because we can create a implant, right? We will put the resection margin around the tumor. So there's a lot of conversation that goes in together with the engineers. I think Prof. Gee would probably have more experience with this, but essentially, once you map out the resection margin, they will make the cutting guide for you to actually do the cuts, and then you remove and you replace with implant. Yeah. The problem is more skin breakdown because you need to do radiation treatment.
Yeah. If Professor Corrado is here, his experience about this.
Yes, the last sentence is right. The problem also is the skin. So usually when we treat tumor, and we also work with the plastic surgeon to find solution for the skin. So rotation or tissue expanders to have more skin. So the planning for the malignant tumor is a little bit more complex, because you need absolutely to have healing skin, also because you have to prepare the patient, for example, for radiation or for chemotherapy. And so in the planning of cranioplasty, we should pay attention also in the planning of the skin, and maybe you may have help about plastic surgeon.
Thank you.
The only thing that I remember is a paper, not malignant, but meningiomas, is a paper that where they observe after growing of meningioma, they observe meningioma cells in the hydroxyapatite cranioplastic. So just to confirm how hydroxyapatite is so biomimetic that also meningioma cells grow inside the hydroxyapatite.
Very true.
Professor Corrado, seldom we actually encounter patients with bilateral decompressive craniectomy. And in such cases, when we plan a cranioplasty, do you prefer to do both the sides in one sitting or one after another?
It depends from the skin status, and it depends on brain status, because sometimes one brain is swelling and one not. Is it possible? It's better to reconstruct both sides in the same surgical session, but also depends if the patient is a healing patient or is a fragile patient, so he can have a long surgical time. It depends on a lot of things. Of course, it's better to reconstruct both sides for CSF circulation, of course. So this is the target is both sides in the same surgical session.
Fine. So thank you all. And with this, we come to the end of the first session of today's webinar. Now we shall move ahead with the next session, which will comprise of 3 speakers. And I would like to invite my co-moderator, Dr. Gaurav Jain. He is Assistant Professor in Department of Neurosurgery, SMS Medical College, Jaipur, India. He is also a member of the Neurological Society of India. Dr. Gaurav, please could you take over the session?
Hello. Thank you, Dr. Amit Chakravarti. Thank you, Dr. Amit Chakravarti, and a very good afternoon from India, and a very warm welcome. There have been so nice presentations and quite healthy discussions, and it has made us aware of so many new things and so many trivial concepts which we actually think daily, but we are hesitant in our younger generation to ask these. I must reveal that I, Dr. Gaurav Jain, feel fortunate to work under Professor V.D. Sinha sir as Assistant Professor Neurosurgery. He has been a guide who instills enthusiasm to do good work. His extensive work on cranioplasty has evolved in the recent years in quality, technique, and results as well, for which I was lucky enough to be a part of his team. Today, we have so many authorities from all over the world. I will like to mention their names: Professor Corrado, Dr. Sinha, Dr. Costas Fontas, Dr. Jay Prashantha Rao, and Dr. Guy Rosenthal. I welcome you all, and also we have with us Harry Mee, Dr. Harry Mee, who's a young trainee at the Rehabilitation Medicine. I welcome you all on this virtual platform. Dr. Costas Fontas, do you hear us? Okay, I think we can continue with the next session. Today we have Dr. Harry Mee with us. Dr. Harry Mee, can you hear us?
I can, yes. Hello. Hello.
Can you hear us?
Yes. Hello. Hello. Hi. Hello.
Hello. Hi, how are you?
Yes, very well, thank you.
Yeah. Today we have with us Dr. Harry Mee, who is in Rehabilitation Medicine at Registrar Post in University of Cambridge in UK. He has been nicely trained and has a special interest in traumatic brain injury rehabilitation. So I now request Dr. Harry to share his screen for his presentation. We'll have the question and the answer session after all the three presentations. Thank you.
Thank you very much indeed. Let me just start. Can I just ask if you're able to see my slide in full?
Yes, we are able to see them.
Fantastic. Thank you very much for the invitation to speak to you all today. My name is Dr. Mee, or Harry. I'm a rehabilitation medicine trainee in the United Kingdom, and I'm part of the traumatic brain injury research team at the University of Cambridge with Professor Hutchinson and Mr. Angelos Kolias, and I have been helping in the development of a core outcome set for cranioplasty following stroke or traumatic brain injury. And I wanted to just spend 15 or 20 minutes today talking a little bit about this. It is a little bit different to the talks you've had up to this point, but I hope we will see the relevance to it in certainly the outcomes and functional outcomes for following cranioplasty. For the first 5 or 6 minutes, I'm just going to talk a little bit about the background, to put the core outcome set as a whole into perspective for those of us who perhaps haven't come across the concept as such. So as we know, when we're developing any study or clinical trial, the research question is key to that. And as part of that, there are lots of methodological approaches to developing that question. And one common one that we will all know about is the PICO, looking at the population, the intervention, the control, and the outcome. And the research question should really have an element of all of those and should be central to any study. Core outcome sets specifically are looking at the outcome of such, both not just from a research perspective, but also from a clinical perspective. And outcomes, as you can see from the right side, can be categorized into 4 different areas. So first of all, we need to look at level 1, which is what is the outcome? What are we interested in? Then level 2 is how do we measure that? Level 3 is how do we interpret that measurement? And then level 4 is the statistical analysis. A core outcome set is looking at level 1. So it's looking at what to measure, not how to measure. A core outcome set specifically is defined as an agreed, standardized set of outcomes that should be measured and reported as a minimum in any given clinical trial of any specific health condition or healthcare setting. The background as such isn't new. It's been around a long time, and a group who is not related to neurosurgery, but this is the OMRACT core outcome set group, which are in a group based from Australia that was started in the early 1990s, looking at outcome measures in rheumatology. And this really set the foundations for the core outcome set work that that many health conditions use today. They developed the initial core outcome set back in the early 1990s in rheumatoid arthritis. And just very briefly, you can see from the right side of the graph that over a number of the last 20 years or so, the uptake in these types of core outcome sets have increased from very small numbers up to a substantially increased numbers in the last 10 years or so. The background to such is when we look at what we call conceptual health frameworks, so ways in which we categorize healthcare, ways in which we're able to standardize approaches to what we do in everyday clinical practice. Within the rehabilitation setting, we often use the International Classification of Functioning Disability and Health, which is here on the left-hand side. This takes the health condition, so for us, traumatic brain injury or stroke and cranioplasty, and then we look at the different areas specifically relating to the body structure and function, the activity, the participation of that activity, and then the integrated environmental and personal factors. Another framework that we'll all know about, although perhaps we won't have related it to the framework specifically, is the Wilson and Cleary Quality of Life framework from the mid-1990s. Again, this is the basis for a lot of the quality of outcome measures that we use, such as the EQ5D or the SF36, have all been structured predominantly from this. What the OMRAC group have done from the development of core outcome sets is combined both of these to produce what is known as the OMRAC filter. And this is a conceptual framework for us to link outcomes and outcome domains to different core areas of interest when we look at both clinical and research practice. And the core areas are mortality, life impact, resource use and economical impact, and pathophysiological manifestations. And it's this conceptual framework, the OMRAC filter 2, that we have used in development of the core outcome set for cranioplasty. Just further to contextualize where we are at the moment with these, COMET is what's known as the Core Outcome Measures in Effectiveness Trials, and it's the overarching body, certainly in the United Kingdom, that oversee the development of core outcome sets for any given health condition. And it's this that we've aligned with. Advantages of core outcome sets are there to increase consistency across trials, to maximize potential for trials to contribute to systematic reviews to key outcomes, and hopefully standardize and make more appropriate outcomes that are relevant to patients specifically. So what we're trying to do here is develop a set of outcome measures that can be standardized and recorded in any clinical or research setting for any health condition. And for us, that's cranioplasty. But why a core outcome set for cranioplasty? Why is this important? Well, as we've heard in the first half of the webinar this morning, there are different reasons for decompressive craniectomies. There are many different neurological baselines post-decompressive craniectomy from those patients who are functionally improving quite well in their rehabilitation setting, the decompressive and the cranioplasty is very much a part of that continued recovery. Those patients who perhaps at a more severe disability level or in a low awareness state where cranioplasty may still be appropriate, but clearly the outcomes for both groups of patients can and are quite different. We've touched on changes in neurological function, so how the cranioplasty can influence that. But then we also need to look at what do we mean by neurological function? Are we looking at functional outcome? Are we looking at physical outcome, cognitive outcome, functional independence? These are all different areas of interest, which all on their own are very important. But I think it's important for us to try and standardize a set of outcomes that can be used so we can have increased ability for meta-analyses and systematic reviews. In developing a core outcome set, there's no one methodological approach for this. There are lots of different ways to do it, but generally it's split into two phases. The first phase is collecting what outcomes are in the literature and are being used at the moment. The second, understand what the core outcome set should contain. This is the flowchart for the COAST study. This is where we've been developing. Phase 1 is that data collection. So we've done a systematic review looking at the current outcomes that are in the literature, and I'll go through that in a moment. And then the second part is a qualitative study. So interviewing patients, interviewing clinicians, interviewing therapists and relatives, just trying to see if there are any other outcomes that perhaps haven't been captured within the systematic review. Those are then all put together and consolidated and put into a way in which we are able to then gain consensus on those outcomes. Again, there are different ways for doing this, but we opted and are using what's called a Delphi survey, which is an anonymized electronic questionnaire where clinicians and all the stakeholders can rank due to the importance of whatever the outcome is. And then I'll go through it in a little bit more detail in a moment. And then hopefully by the end of the Delphi survey, we will have a set of outcomes that have been agreed through this process that we can then put forward for the cause. So the phase one of the systematic review, we looked at outcomes published, or studies, I should say, published after 1990, specifically looking at stroke or traumatic brain injury. We included randomized control studies, prospective and retrospective cohort studies of at least 10 or 20 patients. And we looked at over 200 studies, as the diagrams say there. We found from this 202 what we have defined as verbatim outcomes, and I'll explain the verbatim outcome in a moment when I give you an example of the types of outcomes we've looked at. And we extracted those from the studies. We then grouped those verbatim outcomes into outcome domains. So some of the outcomes were very similar to each other, and we felt it wasn't appropriate to rank every single outcome separately. So we grouped them together into what we've called outcome domains. We then associated these with one of the four OMRACT filter core areas of either life impact, pathophysiological manifestations, resource use, or mortality. And you can see that overwhelmingly so, 94% of studies reported at least one outcome on relating to a pathophysiological manifestation, followed by resource use and economic impact, life impact, and mortality. Sorry. We also did a qualitative study, and I haven't gone into a huge detail of that today, but essentially we used a purposive sampling methodology with both interviews and focus groups, looking at trends in themes that we produced from that. And we have also included some more outcomes on top of the systematic outcomes. This is a scanty diagram looking at the overview of the types of outcome domains that have come from the life impact core area on the OMRACT group. So we overall found 63 verbatim outcomes, and we categorized them into 19 different domains. Because of the number of domains in this area, we then also categorized those domains into different categories, looking at quality of life, psychosocial, general health, function, cosmesis, and cognition. This is an example of the flow chart that I've used, or the chart I've used to try and predefine these outcomes. So on the left-hand side is the overall area, the overall category that the outcome is in. So if we take function, for example, so the overall category is function. The second area is what we call the outcome domain. So that is how I've categorized the verbatim outcomes, and the verbatim outcomes are those ones listed here. Although the development of the core outcome set doesn't directly look at how to measure, so what outcome measures we use, I have categorized those down the right-hand side to correspond with the appropriate outcome domain. So all of these have been taken from either studies in the literature or the qualitative study. So these are all the types of areas that clinicians and researchers often and almost always very appropriately measure in. But we can see just from here the number of different outcomes and outcome domains there are, and therefore the cross comparison from one to another is very difficult. Just briefly here, this is looking and trying to associate the outcome domains on the left-hand side with those of the different types of outcome measures on the right-hand side. And all you can see that the varying different types of outcome measures and the variability in what we try and measure here. So is it global functional outcome? Is it your motor function? Is it your functional independence? And these can all interchange with each other. Another example of the pathophysiological manifestations. So these are looking at more specifically complications, radiological outcomes, neurological outcomes, and some population-based work as well. And you can see here that there are 83 different verbatim outcomes, and we categorized them into 14 different domains. The most commonly reported was infection, and that was about 60% of all the studies we looked at included infection, and overall complications and intracranial hematomas were the others. These infections include, and I haven't included that here, but included 7 or 8 different types of infection. So we decided to include infection as one whole outcome domain rather than self-categorizing them through. It's important to remember that the final core outcome set isn't a definitive, you have to measure this or that. It's just to help guide clinicians and researchers in what outcomes to look at. So this is a similar schematic that I showed before from the life impact, but this is of pathophysiological manifestations. So complications here, infection is the outcome domain, and this relates to all these different types of infection and a couple of the different outcome measures that have been used there. I won't go through this whole diagram here, but just to give a flavor of how we've gone from having the overall outcome category to then splitting it into the outcome domain and then the outcome verbatim. There's obviously crossover, so some outcomes, and it's very important to note that some outcomes can fit into more than one of the core areas in the OMRAC filter. So this is just showing that the main categorization of any one particular outcome domain, for example, in life impact, can still be inputted into pathophysiological manifestation core area and resource use or mortality, and there's linking from left to right. Once we have got and accumulated all of the necessary outcomes from that data collection process, that phase 1 process, that takes us into phase 2. And phase 2 is really where we look at gaining consensus. And as I said before, there are different ways in doing this, but clearly in line with the difficulties we've all faced over the last few years with the pandemic, an online anonymous process that can be completed in somebody's own time and not relying on groups and collaborations in one particular place has clearly been something that has helped this process. So we have used an online Delphi survey. The Delphi survey as a methodological process, I'm sure we are aware of, but just to briefly outline, you have to have at least 2 rounds of the Delphi survey in order to complete that. You can have more than 2 rounds, but essentially all of the outcomes are ranked by everyone who is asked to complete the questionnaire. We have used what's called a Likert scale, and we have asked people or stakeholders to rank each outcome as to how important it is to them. We then analyze that, and then we ask everyone to rescore all of the outcomes. They are then able to see the feedback and the scores from their stakeholder group and can have an overall view of the outcomes across all of the stakeholder groups. The particular participant can then rescore the same outcome with the same score, or they can change their score. We just ask if they change their score, if they change their score, they give a reason for that. At the end of the first round, we also give an option for further outcomes to be included. It's important to remember that this isn't looking at common data elements. So we're not looking at baseline characteristics or surgical interventions here as a CDE. That is a separate entity and is an equally as important piece of work that should and hopefully will be done. This is looking at the outcomes specifically. At the end of the round 2, if we feel we've reached a consensus, we can take that forward into a consensus meeting, and I'll explain that in a little more detail. So the process of the Delphi itself, we've had 4 stakeholder groups. The first is patients and relatives. The second is surgeons. The third are non-surgeons or physicians and intensivists. And then the 4th group are nurses, allied health professionals, and researchers. So hopefully a broad range of people who have an interest in cranioplasty, not just clinically necessarily, but also from a research perspective. We have completed the round 1 of the Delphi survey to date. I'm in the middle of analysing all of the 50 outcomes ready for the round 2. We've had a good spread of interest. We had 194 register for the Delphi survey itself and 153 completed the whole round. We were always going to have a lower number of patients given the nature and the cohort of patients, but I was really glad we ended with 16 patients. We've had 70 surgeons, 37 physicians, and 30 nurses and allied health professionals and researchers. So a good spread across the 4 stakeholder groups. The way the Delphi runs in round 2 is, as I've said already, all the outcomes are scored again, feedback is available, and then the pre-agreed consensus criteria is applied. And this is the key part when we look at gaining consensus. So the scoring is based on a Likert scale, as I've said. So if somebody doesn't think that particular outcome is important, you score it 1 to 3. If you think it's important but not critically important, you score it 4 to 6. And if you think it's critically important, you score it 7 to 9. For a consensus, so for an outcome to be put forward as into the final core outcome set, the definitions are as they are there, and 70% or more of the participants have to score it as critically important, and less than 15% score it as 1 to 3. Consensus out, which means that the outcome is not considered for inclusion, the criteria is as it is there. Obviously, there will be a number of outcomes that don't meet either of those criteria, and they're the ones that are then discussed in, well, probably via Zoom, but in a face-to-face consensus meeting. So the consensus in one that meet the consensus in criteria will be in the final set, regardless of the consensus meeting. The consensus out one won't be discussed, and the rest will be. It's important to note that you have to gain consensus in each of the 4 stakeholder groups separately in order for the outcome to go through. This is to stop the bias of one group being larger than another group. So the consensus has to be met across all 4 groups. If consensus is met in 3 out of 4 groups, it won't automatically be included, but that may be a point of discussion in the consensus meeting, and may well end up in the final group, but just hasn't met that initial criteria. The consensus meeting itself is made up of the steering committee who've overseen the whole of the project, also key stakeholder group members, of which we will be inviting a number of people to attend this, and there will be open discussions in each of the stakeholder groups before the final consensus voting. It's important to note that you can't complete round 2 of the Delphi unless you completed round 1 of the Delphi, because obviously you haven't been able to see that. Hopefully at the end, we will then have an agreed consensus of a set of outcomes that should be measured and reported on as a minimum in any given trial or of cranioplasty. This can be overseen into clinical care as well, and is, as I said, isn't supposed to be a definitive, you have to measure this and this. It is just a guide on what to measure. So hopefully over time, this isn't something that's going to happen overnight. We should be able to have an increased standardization of the types of outcomes. Clearly the work on from here is to build this into a formalized outcome measure for cranioplasty, and hopefully build that into our longitudinal 5-year follow-up study, which we're starting alongside the cranial reconstruction registry. So just in summary, there's a huge heterogeneity of outcomes in cranioplasty, and so I think this is important, so we have a better understanding of what to measure in the future, and hopefully this will help guide future work. Thank you very much. Any questions at all? I'm sorry I overran slightly. Please, I'm happy to take them now or at the end of this session, or to be emailed from the bottom there. Many thanks.
Thank you, Dr. Hari. It was a very nice presentation, and I must comment that you've included the things which the patient and the attendants or the family members of the patient really wants. That is the cosmesis and the improvement in the functions for the patient. They are more concerned about these 2 things, and you've rightly analyzed and summarized them. There one question is from my side. We can take the questions after the session. So,
okay, of
and
course.
Okay. And I request all the participants to kindly refer the name to whom the question is being referred. Maybe Dr. Harry or maybe Dr. Rosanthal, who will be now presenting. That will be easier. So we now move on to our next presentation. We have with us Dr. Guy Rosanthal, who is an associate professor of neurosurgery and director of neurotrauma and neurocritical care at Hadassah Hebrew University Medical Center in Israel. He has served on the guidelines committee of the Brain Trauma Foundation's guidelines for the management of traumatic brain injury. He returned to Hadassah and led the neurotrauma program and directed the neurosurgical intensive care unit. He has introduced cerebral monitoring techniques in Israel and also established an animal laboratory to study the cerebral physiology under conditions of brain swelling and elevated ICP. He has continued to publish works in this field and has published many studies. In addition to his clinical duties, he is also the chair at the Israel Neurosurgical Society Examination Committee for the written board certification. I now request Professor Guy Rosanthal to kindly share the screen and please start with his presentation. Dr. Rosanthal, can you hear us?
Yes, let me start the screen
Thank
sharing.
you. Dr. Rosanthal?
Yes, I also have seem to be
okay.
having a problem with the screen sharing. So I might have to leave and come right back, unfortunately.
Okay.
Let me see. Let's see if we can do this.
Welcome, Dr. Fontes.
Do you want me to take the opportunity and try to give my presentation and then Guy can deliver his? I mean, I don't know.
I think that will be. I think Dr. Guy has joined. And Dr. Guy, can you hear us? Dr. Guy, can you unmute? Unmute yourself.
Yes, I can hear you. Let me try one more time, but no,
Okay.
let's have Dr. Fontes go before me.
Okay. Okay.
All
You're
right,
welcome,
let's
Dr.
see.
Fontes.
Thank you, sir. Let me see if that works okay. Can you see my slides?
Yes, we can see.
Perfect.
But can you? Yeah. Yeah.
Okay,
Now they are
great.
perfect.
So I have to just thank the organizers for their kind invitation, particularly Professor Sia. As I was telling you, these are my financial disclosures. My financial relationships will not affect in any way my presentation today, since I'm not going to discuss any products of these two companies. I live and practice in Larissa. Larissa is in the heart of the Greek mainland. And I work in the busiest neurotrauma surgical service in Greece, and by far the busiest from the standpoint of decompressive craniectomy. The catchment area of where I practice is approximately 1.5 million people. And what I'll try to just cover within the next 15 or 20 minutes is to just give you an update regarding the existing controversies regarding the
differentiation of hydrocephalus, particularly post-traumatic hydrocephalus versus ventriculomegaly, and then try to define the actual incidence of post-decompressive craniectomy hydrocephalus. And finally, and I think most importantly, to see how we manage hydrocephalic patients when we come to restore their cranial vault to perform a cranioplasty. So it's been more than 20 years since that original presentation by Marmaru and his co-workers appeared in the pertinent literature. And actually what they did, they reported the incidence of ventriculomegaly after severe closed head injuries and the incidence of hydrocephalus, of clinically evident hydrocephalus. And you can see that there is a tremendous difference between these two groups. So in other words, whoever has enlarged ventricles, that doesn't necessarily mean that the patient is hydrocephalic and needs some kind of surgical intervention for addressing this issue. And there is no doubt that the patients that they develop finally hydrocephalus, they do have worse, the worst clinical outcome, have significantly more complicated outcome compared to the other patients. This is nicely reflected on that publication which appeared in 2017. And you can appreciate the mismatch between the reported incidence, which in the literature is anywhere from 1% to 45%. Actually, the authors reported that the observed incidence in their institution was something less than 11%. But the important thing is that they attempted to introduce a scale to identify parameters and develop a scoring system for these parameters for seeing which patients may develop hydrocephalus. And you can see among them, the patient's age was a prognostic factor, the duration of coma, the Fisher grade whenever there was a traumatic subarachnoid hemorrhage, the performance of bilateral decompressive craniectomy, and also the existence of brain cerebral herniation through the cranial defect. And actually, there was another study which was recently published. It's a Nordic study. It comes from Scandinavia. And you can see that they reported on the experience, single center experience with more than 800 patients. And again, there is that tremendous difference between ventriculomegalic patients and patients actually requiring a shunt insertion for solving their problem regarding to the clinical hydrocephalus. And again, they identified several parameters, as this was the low admitting Glasgow Coma Scale score, and particularly the motor component of that, the presence of severe diffuse traumatic subarachnoid hemorrhage, the presence of meningitis upon the admission or during the hospitalization of the patient, and also the performance of a decompressive craniectomy. So with that in mind, we come to another gray zone if there is an association between decompressive craniectomy and hydrocephalus. And you can see that there are several different opinions regarding this issue. We know that there is significant discussion how often the hydrocephalus is. And I think that the problem is how we define hydrocephalus. Is a clinical entity that is defined by imaging criteria, or this is a clinically evident entity. So depending on that, I think that we'll find different numbers. And this is a landmark publication, which was approximately 10 years ago was performed. And you can see that the difference between the ventriculomegalic group and the hydrocephalus group is not that large. So this is not, although reproducible in the pertinent literature, and I think that there are several other studies published on the subject that they prove that there is a pretty significant difference between the ventriculomegalic and the hydrocephalic patients. Again, there is no doubt, though, that the presence of post-traumatic hydrocephalus or the presence of post-decompressive craniectomy hydrocephalus constitutes a really bad prognostic factor for these patients. And there is a pretty significant variation in the literature regarding the actual incidence of post-decompressive craniectomy hydrocephalus. And you can see that the older data, they have a pretty significant variation, anywhere from 0 to 52% almost. The newer data, the last two decades, I think that the incidence is anywhere from 0 to 36%. And I think that we have to admit, all of us, that this is an entity that is underreported, definitely underreported. And I have characteristically there the results of the rescue ICP, which was not targeting the incidence of hydrocephalus, but there is no report in that study regarding post-traumatic or post-decompressive craniectomy hydrocephalus. And I think this is a problem that is underreported. This is a nice study, a meta-analysis study with more than 2,400 patients undergoing decompressive craniectomy. And you can see that they actually try to divide the two groups, the adult patients and the pediatric patients, and they have reported the incidence as this produced by the literature. And this is anywhere to close to 13% for adults and approximately 37% for pediatric population. And the overall incidence of hydrocephalus associated with the performance of decompressive craniectomy, as you may see, it's something more than 17%. I think that will be of interest in the future to see another group here, the geriatric patients, patients over 70 or 65. I don't think that we can easily define a cutoff age limit, but I think that will be interesting to see in the future. However, the management of patients with hydrocephalus is a real problem. It's not a theoretical problem. So we have to provide particularly younger colleagues with some idea of how we are dealing with patients like this or this. Do we do something? Do we insert a ventriculoperitoneal or a lumbar peritoneal shunt before performing the cranioplasty? Or we just go with an external ventricular drain or a temporary lumbar drain or serial LPs? And even if we decide to just perform a VP shunt insertion, are we going to do that before the cranioplasty, at the same time with the cranioplasty, or after the cranioplasty? And unfortunately, I don't have a clear-cut answer to that question. And of course, there are arguments for performing an insertion of a VP or an LP shunt before performing the cranioplasty. And the major advantage of that is that you don't have the effect of hydrocephalus, the prolonged effect of hydrocephalus if you insert something before the cranioplasty. But in the literature, there is evidence that the complication rate in this group is significantly higher. And actually, the shunt revision rate in this group of patients is higher too. And Corrado Iaccarino nicely reported Chosnika's paper several years ago, which proved that the brain compliance is different when you do have an open cranial vault. So keep that in mind. What about the literature regarding simultaneous insertion of a shunt to the cranioplasty? There is again evidence that there is higher perioperative complication rate among these patients, and also again an increased shunt infection rate in these patients when you perform both procedures at the same time. And the problem, if you just wait and just perform your cranioplasty and then insert a shunt, either a VP or an LP shunt, this may intensify, of course, the effects of hydrocephalus to the brain, and also may make the performance of the cranioplasty, of the actual cranioplasty, more difficult from technical standpoint, because you have to deal with an enlarged ventricular system and occasionally with a protruding brain through the cranial defect. So I have to go back to that consensus statement that Corrado has already mentioned, and I think that is seeking for a renewal and an update, particularly for including patients with malignant MCA infarct or things like that. And actually, this consensus statement tried to address exactly these issues. In other words, do we need to perform a cranioplasty before the CSF diversion, either VP or LP? And you can see that the agreement was quite high among the participants. Almost 96% of them agreed that we need, if we have to insert a shunt, we need to do that after the cranioplasty. Similarly, the question is, how are we dealing with patients that there is some kind of enlargement of the ventricular system, and that may make the performance of a cranioplasty more difficult. You can see that several people use external ventricular drains, several people use temporary lumbar drains, and I know that there are several people use serial spinal taps, although there is not enough literature support for this policy. But you can see that the agreement is again quite high. Many people use that, almost 95%. And in regard to how we follow these patients, if we decide that we'll perform first the cranioplasty, and then if the patient develops clinically evident hydrocephalus, then you can see that there is an agreement of 92% that this group of patients requires a pretty significant monitoring for developing any kind of suspicion, clinical suspicion of hydrocephalus. So with that in mind, I have to just bring up the other question that comes with the hydrocephalus address. This is what kind of type of valve we're going to use in these patients. And I think that programmable valves are preferable, but we need to keep that in mind that the cost of these valves is significantly higher. And if you are working in a low resource country or in a low resource health system, this may be a serious consideration. This is a publication that actually appeared after the consensus meeting on cranioplasty. And this is a small series that comes from Taiwan, as you may see, single center institution, retrospective, and they included 49 patients, and actually 32 of these underwent a simultaneous VP shunt insertion to the restoring cranioplasty. And you can see that contrary to what had been previously published, their overall complication and also the reoperation rate among these patients were quite similar. So this is something that you need to keep in mind. And I think that if we just move forward to my conclusions, try to wrap it up, I would say that ventriculomegaly is a really common finding, an imaging finding among patients suffering severe closed-head injuries. But it seems that the actual percentage of clinically evident hydrocephalus, the actual percentage of patients really requiring surgical address of their underlying problem is significantly less frequent. And of course, we do have some tricks such as EVD or lumbar drain temporary placement for making things easier for us from technical standpoint for performing the cranioplasty. And then we need to closely follow these patients and see for any kind of clinical suspicion or any kind of alteration of their neurological status and detecting hydrocephalus and properly addressing that problem. With that, I would like to thank you, and I'll be more than glad to answer any questions you may have. Thank you so much. And I really apologize for the inconvenience with all these technical problems. Thanks a lot.
Thank you, Dr. Fontes. And I'm sure that the young neurosurgeons in making would have gained a lot from your presentation, and especially the questions how to deal with the ventriculomegaly oblique hydrocephalus in decompressive craniectomy patients. And thank you for the presentation. And now we move forward for the next presentation from Dr. Guy Rosenthal. We'll be taking the question and answers after this presentation. Dr. Rosenthal? Dr. Rosenthal, can you hear us? Dr. Rosenthal, you will have to unmute yourself.
To unmute.
Yeah. Okay, now we can see your presentation.
Okay, can you hear me?
Yes, we can hear you.
Oh, good, thank you. Sorry about all the technical issues. It really is a great pleasure to be here. And we've heard some wonderful talks, and I'll try to address some of the issues around some of the complications of cranioplasty and how we've dealt specifically with infections and assessing bone resorption, at least on an institutional level. I think we heard from Dr. Rao and some of the other speakers a wonderful general overview of the some of the complications that we face after cranioplasty. And I think that in general, cranioplasty is an often overlooked procedure in neurosurgery. I mean, we say we're just putting the bone flap back on, and what could possibly go wrong? And as we've seen, that is certainly not the case, because if we look at the literature, and we've seen that today the complication rates in this procedure are certainly high, and they can be as high as 15 to 36% of autologous bone. And again, as we've heard, it depends what you're measuring and what you're calling a complication. And actually, the literature says that there's really is not much difference in the rates of complication between autologous bone and a synthetic implant. Now, why we do cranioplasty, we've heard, first and foremost, to protect the brain, to repair the aesthetic defect, and to improve motor function. Well, yes, we see that sometimes. The reports are a 5 to 10% improvement of motor function, specifically after cranioplasty. And probably, as we've heard, a lot of that has to do with repairing the hydrodynamics of the brain, which are so important. Now, as far as autologous bone cranioplasty, we know by the literature that there's a high overall complication rate, 15 to 36%, and we should probably divide those into short-term complications, which we've heard about, infection being the first and foremost, because infection almost always requires implant explantation. And, I think that's what we all fear. Bleeding and seizures, also complications that we've heard about and are certainly important. And I think in the long term, the most common complication is bone resorption, and we'll talk a little bit about that today. In neurosurgery in general, probably in life, it's important to plan ahead when you're doing anything. And certainly that's true when it comes to complications. And what we tell our residents is that when you're planning the initial decompression, you have to be very careful that the margins of the bony flap that you extract, and it has to be a big flap like we've heard today, at least 10 by 14, maybe 10 by 15 centimeters. It should all be within the margins of your skin flap. Otherwise, you're going to get into complications when you come and do the cranioplasty, because you'll have the incision directly over the bone or the implant that you're inserting in. So I think that's an important point. Now, we had a high rate of infections at our institution, and we tried to change that. And I want to talk a little bit about some of the work that we've done, that Dr. Hooley, one of our residents, has looked at how we instituted a program to try to reduce the rate of infections after cranioplasty. And as we've heard about, it's more common after bifrontal decompressions. You have a higher rate of infection and other complications. And like I said, we did have a high rate of postoperative infections. And when you do have these infections, they almost always require removal of the bone flap. And so we initiated a regimented program attempting to reduce the incidence of postoperative infections. And that was about 12 years ago now, following cranioplasty. We included in our study all patients over 16 years. So these are adult or the greater age pediatric patients who underwent cranioplasty. And we instituted a 7-point program to try to reduce infections. During decompressive surgery, bone flaps were cleaned and rinsed with gentamicin-containing solutions. And then, of course, we have a dedicated -80°C freezer with appropriate temperature controls and alarms. During the cranioplasty, of course, preoperative antibiotic dosing, that's pretty standard. And during the cranioplasty, we also have meticulous wound preparation. So it's not just enough to shave the skin. We do what we call a double shaving to try to clean everything off that skin. So if the patient has dandruff like you see here, we'll shave it again and then clean it off, and so that we start off with a meticulously clean wound. And then we do double gloving throughout the surgery. So we start the surgery with double gloving, and then we have frequent changing of the gloves, and that's easy to do when you're double gloved, so that whenever you're touching the bone flap or the implant, you're changing your gloves so you don't have blood or anything on your gloves. And I think that's an important point. And then during the surgery, before we implant the bone, they've been cleaned obviously before they go in the freezer, but we clean it again and we remove all remaining soft tissue on that bone flap, so that if you're putting on an autologous flap, that you have really a very clean bone flap that you're putting on. And then in all cases, I think this is pretty standard, we leave a subgaleal drain. And then after the cranioplasty, we do continue antibiotics, usually just a first generation cephalosporin, until the drain is removed. And then the patients are instructed in a wound care regimen, the patients and their families. We don't always have a cooperative patient, as you know, and to clean the wound with a very gentle shampoo and then not touch the wound, just put on the shampoo and let water clean it until it's clean. And we had 99 patients who underwent 106 cranioplasties. I think the male-female ratio, given that most of these are traumatic brain injury patients, not all, is pretty standard: 75 males, 24 females, relatively young, mean age of 37 plus 16 years, 76 of autologous bone and 30 with synthetic implants. We use mostly PEEK, as we've heard today. 65% of the patients, so almost 2/3, were trauma-related, 21% were non-traumatic, and 9% were ischemic stroke. 95 were unilateral cranioplasties after a large decompressive craniectomy, 59 on the right and 36 on the left, and 8 patients bifrontal cranioplasty, 3 patients underwent bilateral cranioplasty. So we had a mean of 6 plus or minus 3 months after the previous surgery, a mean of 5 plus or minus 2 hospital days, and no 90-day postoperative mortality. The bone flap was removed due to infection in 3 patients, 2 with autologous bone and 1 with synthetic implants. So that's an infection rate of 2.8%. So we were able to get down our infection rate significantly. Bone resorption, I'll talk a little bit later about that, about some of these other complications. Postoperative hematoma. We had 4 patients who underwent surgical evacuation of a postoperative hematoma without bone flap removal. So there, if it does occur, most of these are small hematomas that resorb by themselves, but in 4 patients, we did have to go back in there and remove the hematoma, but we were able to replace the bone flap in all of those. Hydrocephalus, we've heard about today, and 5 patients needed a VP shunt insertion after the cranioplasty, 1 during the same hospitalization. So yes, as we've heard today, you need to be aware that some patients will deteriorate because they had hydrocephalus before, and they can deteriorate quite quickly. Seizures in 7 patients, so just under 10%, and 2 were focal seizures and 5 were generalized seizures. So we do use 1 week of prophylactic anti-seizure medications, usually Keppra, in that first week after the cranioplasty. So we do that. We had no systemic complications of pneumonia or PE or DVT, and but I think that's important. I think we've heard about that today. I think you have to ensure that the patient has no infection, no open wounds, no pulmonary infection before you take them to a cranioplasty, no cardiac events. And so I think that implementing a regimented program, to have something in place that's regimented, that you make sure that all surgeons do with all the time in the same way, to reduce the infection may help to achieve a low rate of post-surgical infections that require revised surgery. And we were able, at least at our institution, to get that down to about 2.8%. And as we keep going along, we've gotten that down to just under 2% at the current level. Other complications, though, including postoperative hematoma, seizures, and hydrocephalus should be anticipated. And bone resorption should be taken into account regarding this regimen, and maybe we can talk a little bit about that. So if infection is the most feared short-term complication, I think in the long term is what we all watch out for with autologous bone cranioplasty is bone resorption. And how do we handle that? And I think one of our other residents, Isel Ramirez, looked at that very closely. And one of the things that we thought about is that we probably want to be able to quantitate this problem in order to get a better handle on it. So we all know what this looks like. You know, here's a patient a few months after autologous bone cranioplasty, and here you can see on the three-dimensional CT reconstruction, and here you can see what it looks like in real life when you explant it. The bone becomes much thinner, and it loses a lot of the surface area coverage, and the patients will redevelop some of these symptoms that they had when the bone flap was off. So when we look at the literature, so what's the reported rate of bone resorption? Well, if you look at it, the range is 1.4 to 50%. So what does that mean? I mean, that's a huge range. That's really huge, 1.4 to 50%. And I think it really depends how these individual reports and authors define bone resorption. I mean, is it an all or none phenomenon? Does it count if it's a little bit or a lot? And I think the bottom line is that we need a better definition for bone resorption when we talk about it. And so we wanted to describe a method to quantitatively assess bone resorption and to determine whether this method predicts the need for reoperation, because that's what we really want to know at the end of the day, isn't it, whether the patient's going to need a reoperation or not. And so we looked at all patients that underwent autologous bone cranioplasty following unilateral decompressive craniectomy over an 8-year period. And our inclusion criteria was that they had to be non-pediatric, so this is the adult population greater than 18 years old, and they only had to have a unilateral decompressive craniectomy. We weren't looking at the bifrontals, and as far as the indication for decompression, it had to be traumatic brain injury or CVA. So these were ischemic CVAs or hemorrhagic CVAs. Exclusion criteria, we talked about it, bifrontal decompressive was not included. We excluded all the patients that had penetrating brain injury. I think that's a different thing altogether. Decompressive craniectomy, obviously for infectious etiology, was not included. So if we had in some patients who underwent because of abscess or empyema or whatnot, were not included. And as far as the CT imaging, they all had 1 millimeter cuts, which were performed in all patients 1 day after the cranioplasty. And then the follow-up scans were obtained per clinical indication at regular follow-up. And then, so we used a program to be able to model the bone flap that we replaced in a 3-dimensional fashion and to quantitate it. And so this is what it looks like. So here is the bone flap, the autologous bone flap reconstructed on that 3D imaging program. And we defined what it looked like on the day immediately after the cranioplasty. And so we got imaging on the day after cranioplasty in all these patients as 100%. And here you can see 22 months later, so that's just short of 2 years. Here's what it looks like 22 months later. And if you measure it by volume, so that patient has lost 16% of their volume. They have 84% of their volume left after 22 months. And that's not bad. As you can see, you know, they have a couple little defects there, but more or less the brain is protected. It's a good aesthetic result, but they do have some. Now compare that to this situation. Here's what it looks like the day after cranioplasty. So 100% by definition, that's what we're defining as 100%. And 36 months, also not so bad. They have 87% of their volume left and they're doing fine. But it can be different. Here's what it is 100%. 3 months later, this patient is already down to 68%. And you can see sort of that moth-eaten appearance in the bone flap. And here's what it looks like 6 months later in that particular patient. They're down to 42% of their volume. And this is the kind of patient who's going to need repeat surgery. This is where you don't want to be. And they had reoperation with a synthetic implant. Another example, 100% at day 1. By 7 months, they're at 55%. And then a year later, look what's happened. And they have significant portions of their brain which are now uncovered. And this patient is also going to need reoperation. So in the surgery, we use a patient-specific implant. In almost all of these patients, I think we, like we heard from Dr. Rao in Singapore, we usually prefer a PEEK implant. And in most of our patients had the PEEK implant implanted. We've had good experience with that. We've actually published a joint publication with the group in Singapore reporting our results. And we've had very good aesthetic results with that and relatively low infection rates. So in all patients, if we look at all comers, the mean bone flap, as far as the resorption, they retain 69 plus or minus 24. So that's a broad range. But that means that all patients will have some loss of the bone over time, and the mean is a loss of 31%. So what's severe bone resorption in our mind? In our mind, severe bone resorption was a bone loss of more than 50%, and we'll see why we got to that conclusion. Of the 46 patients, you can see who had to undergo reoperation. We had 10 patients who actually had to undergo reoperation for bone resorption. 9 patients who had to undergo reoperation. Of those 9, 10 had greater than 50% bone loss according to this quantitative method. So 9 out of 10 patients who had greater than 50% bone loss had to undergo reoperation. If we look quantitatively at the patients who had to undergo reoperation versus those that didn't, so you can see 78% of the volume was retained, so 22% bone flap, loss of the bone volume. So it's there, but they can live with that. And the patients who had to undergo reoperation, they've lost 60% of their bone volume. They had 40% remaining at the time of reoperation. So that is a significant result. Now, another interesting thing when you look at it quantitatively is that yes, all patients have some degree of bone resorption, but even those that do, the process usually stops after 18 months. So here you can see someone who's lost a lot of bone at 18 months. This was an elderly patient, so she wasn't deemed a candidate for reoperation. But at 30 months, when you look at her, the process hasn't really continued. It stops after 18 months, this process of bone resorption for whatever reasons. And it's clear we don't understand the pathophysiological reasons for that, but there is a stop. And you can see that when you look at the patients, both who've had severe resorption, they reach a plateau after 18 months. And it also is true for the patients that have a little bit of resorption, after 18 months, there's this plateau effect. So by studying it quantitatively, we are able to learn something about the process itself. In conclusion, I think that doing this is a simple and reliable way to quantitate the degree of bone resorption. It gives you an objective way of looking at it, and it's probably better than saying, well, it's just a little bit or a whole lot. It gives you a number, and you can do something with that number because it allows you to better decide who needs a reoperation, because it certainly does correlate with the need to reoperate. I think that using a quantitative method can help define the time course of bone resorption, which is also important. And we can see that a plateau, at least with our preliminary results, is reached after 18 months. Like I said, we usually use PEEK patient-specific implants. We've published those results, and I think that we can achieve a good aesthetic outcome, as you've seen with PEEK. We also always use the tacking sutures, like we heard from some of the other speakers, and I think that's important, and you can achieve a good aesthetic result. Even without bifrontal defects, it gives you a good result. And I think that in conclusion, cranioplasty, like we've heard, is certainly a rewarding operation. I think it can improve the patient's quality of life, but you have to, just like in all neurosurgical procedures, have meticulous attention to detail and to anticipate the complications. Also, I think this was mentioned in some of the discussions. I didn't talk about this, but certainly when you have penetrating and blast injuries, military type injuries, it's key to have a plastic surgeon on the team. I think we've heard about the importance of the skin in these operations, and sometimes you will require having a balloon expander in there before you go in there. But it's important to have a good plastic surgeon that's experienced with these problems as part of the team. It's important to plan ahead and to do the decompression right, because if you do the decompression right, then I think you're going to have a much easier time doing the cranioplasty. It's important, I think, to have an institutional program to reduce the rate of infection, like we've heard, and to follow closely patients for bone resorption, because in the long term, if you do autologous bone cranioplasties, that's going to be their biggest problem down the road. And with that, we'll take questions, and I thank you for your attention.
Thank you, Professor Rosenthal, for such an informative presentation, and I fully agree that the cranioplasty is rewarding both for the doctor as well as the patient. And it has been clearly defined by the Harry Me presentation by Dr. Harry, that the cosmesis and the functionality of the patient is important post cranioplasty. I now open the platform for the questions. There's a question from Dr. Uday Gupta. How do we differentiate between bone resorption versus skull osteomyelitis after cranioplasty? I think this is for both can answer, Dr. Rosenthal and Dr. Fontes. They can give their different views.
I mean, in our experience, with our bone resorption, there hasn't been an infection. When we sometimes send a culture of the bone to make sure of that. We send it sometimes for pathological examination. And I think that when you have an infection, it's usually pretty obvious. It's usually pretty obvious, and it will present quite quickly after the operation. I think that's different than the bone resorption that we're seeing, 9 months or sometimes a year out. But I think that this is an issue which will require further study, because there haven't been much pathological studies of these bone resorptions.
We also have some infection rate that is low enough, but usually the patients present in a delayed manner, that after maybe few months, 3-4 months, they are coming with small speck of maybe some infected pus, and initial part of the post cranioplasty, they are doing perfect. And this can be resolved by, I think, your 7 steps, which you've told: double shaving and preparing the wound well, and non-touching and giving the baby shampoo. That will be better, I think. So we have another question from Dr. Amit Chakravarti. The timing of redo cranioplasty after initial cranioplasty fails due to infection. That is also for you, sir.
So, I think we've heard some of the debate around this issue today. And our personal institutional preferences, we usually wait 3 months. And, I've tried the early cranioplasties in the past. And, technically, I think what you want there is this good layer of what I call pseudo dura. I mean, part of it is actual dura, and part of it, is this tissue that grows and basically functions as the dura covering the brain. And when you do the dissection, and we haven't talked about some of the technical aspects of cranioplasty, but that dissection is so important. Unlike other neurosurgical operations where the opening is usually, quote unquote, the easy part where nothing's going to happen, if you don't get the dissection right and don't get the tissue plane right in a cranioplasty, and if you have a very thin dura under there, you're going to get into complications, because the worst complication that you can have is a CSF leak, because then that will if it leaks through the wound, you're going to get an infection. And so I like to have a nice layer there that I know that I can dissect out safely. And for that, in my experience, I found that you have to wait the 2 or 3 months, and that's why we wait. Now, I think we've heard that, is it better to do it early because the patient will improve neurologically? And I think that's a very difficult issue to sort out because part of that improvement is the natural history that TBI patients, for example, have in these first 3 months. And I think, we're going to have really well-defined studies that almost randomize the patients in order to sort out these issues of whether that's natural history or whether we're doing something with cranioplasty. The one thing that I think that does help is the motor deficit. The motor deficit after the cranioplasty will get better in a minority, but in a significant minority of the patients. But I open that up to the other speakers because it's a controversial issue.
So we have a question from Dr. Corrado for you. It says, do they perform seizure pre and post-op prophylaxis for all patients who undergo cranioplasty? And what do you think?
I didn't hear the question exactly. Is that seizure prophylaxis is the question?
Yes, sir. Yes, sir. He's asking, do they perform seizure pre and post-op prophylaxis for all patients undergoing cranioplasty? And what do you think about the modified trauma flap with modified cut knot anterior to the tragus, but in retro-auricular position?
Okay, so regarding the seizure prophylaxis, many of our TBI patients, some of the other patients, have seizures, so they'll come in on anti-seizure medication. But if they're not, then what we do at our institution is give them 1 week of seizure prophylaxis after. I usually initiate that at the time of surgery or in the immediate postoperative surgery period, because as I've said, we've seen about a 10% rate of seizure for whatever reason in these patients after cranioplasty. So I think giving a patient Keppra for a week, probably no great disadvantage. And we've probably prevented a few seizures by doing that. I want to be clear, there's no evidence-based medicine for that. So there's no evidence-based medicine answer, but that's been our procedure. Regarding, I do want to mention one more thing about that for the residents. As far as the technical aspects, what we tell our residents is never use the monopolar during cranioplasty surgery. For other surgeries, when we open, we often use the monopolar. Here, you have skin that's over the exposed pseudodura and brain. If you use the monopolar, the heat transfer, I've seen horrible seizures, even status epilepticus when that has been done. And so never use that. Always use the scissors. It takes more time, but do that. And I think that's an important point. Regarding the second question, I have to say I don't have much experience with that. So I will defer to the other speakers to see if they do have some experience with that.
Professor Fontes, can you give your views on this? The retro-auricular incision or the incision anterior to tragus?
I don't have experience either with retro-auricular, so I cannot make many contributions to that. And I totally agree with Dr. Rosenthal's comments regarding the seizure prophylaxis, particularly for penetrating injuries. I think that it's a good add-on.
Professor Sinha, if you can add on.
Yeah, thank you, Professor Harry, for your Dr. Harry. Thanks for your excellent presentation. And as far as the rehabilitation and all these post cranioplasty, we have in infancy, especially the low middle income countries, we don't have much facility for rehabilitation and outcome of the patient. Do you have any guidelines for rehabilitation for these patients? Or they are same for as for the other for other TBI cases?
Yes, thank you very much. No, I don't not specific guidelines for general rehabilitation. I think it's something that would be really useful to have, and maybe some ongoing work from this standardization could be looking at that. So I agree, even small amounts of, and rehabilitation doesn't have to happen in inpatient settings necessarily. Involvement of families and outpatient work is extremely valuable as well. And so, yes, I think it would be really wise to get some standardized guidelines together. But no, I haven't got any specifically myself.
Okay, thank you, Dr. Fuentes. You very nicely cleared the difference between the ventriculomegaly and hydrocephalus. And in your series, you have more the hydrocephalus in the children compared to adults. Any cause of pathophysiology difference for youngsters? There are so many youngsters on the webinar now. Second question, do you have any blood flow studies after cranioplasty, after B patient or before B patient? Do you have any such study with you?
Okay, in regard the first question, this is what exists in the literature. There is higher incidence among pediatric patients. And I think this may be related to the difference in the pathophysiology of developing that ventriculomegaly. The fact is that the brain compliance is better in children, so there is much pressure there, and this may diminish the group of patients with ventriculomegaly. So most of these children who finally develop enlargement of the ventricles, actually they do have clinically evident hydrocephalus too. I think this is the most possible explanation. Now, in regard to the second question, I think that in my institution, we perform a cranioplasty and then we insert a shunt. And even in cases that this is difficult from technical standpoint, we just use an EVD or a lumbar drain for a certain period of time, up to 6-7 days, and see if we can solve that problem. And I have to say that in the vast majority of cases, this problem is solved. So it's a small percentage, around 6 to 7%, that require finally shunting. And I see another question here about the usage of endoscopic third ventriculostomy, if I see well in the chat box. And I think this is a great question. I don't think that there is a lot of evidence in the literature regarding the role of ETV in what we used to call communicating hydrocephalus or obstructive hydrocephalus at the periphery. But there are a few presentations, mostly coming from Italy, that they report really good results with the ETV in cases of shunt revision or in cases that you do have some kind of normal pressure hydrocephalus or other secondary hydrocephalus, the old referenced communicating hydrocephalus. But we need to keep in mind that this series report on a really limited number of patients, and these are carefully selected patients. So I don't think that this will be working on every single patient that had some kind of problem with shunt revision to just go to an ETV for these patients, but maybe a viable option for certain patients with a really meticulous workup, preoperative workup. For example, if you perform a CNMR on these patients, you may be able to appreciate the stroke volume, and this may be the group of patients that they have some kind of functional obstruction. So I think that this may be a tool that we can use it and select patients that they may respond to an ETV.
Thank you for your answer for this question, sir. Actually, recently we had a patient who was quite unlucky. He had a decompressive craniectomy, and as per your presentation, he had a poor prognosis because he developed hydrocephalus, bulging flap, and we did a shunt. After he came with the sunken flap syndrome, he deteriorated. We did a cranioplasty. He developed EDH, though tacking sutures were done, but the sunken flap was large enough. The EDH was removed. Then again, we did a redo cranioplasty of the same flap, but the patient was in poor GCS. And later on he came, we did a shunt revision because he was showing hydrocephalus again. And later on we did an MRI, as you now suggested. And in that we found that it may be the normal pressure hydrocephalus which is like obstructing, and the lateral ventricles were more dilated. So we planned, rather than do the revision of the shunt, the third shunt, we decided to do the third ventriculostomy. And this was the case under Dr. V.D. Sinha sir, and I was in the team. So the patient improved, and we could go without the revision of the shunt. So that time we realized that yes, it can be one of the options in very few selected patients, sir. So I invite Dr. Corrado. Sinha sir, you wanted to say something?
Yeah, just I want to ask Dr. Rosenthal, because he enumerated very nicely the 7 steps how to reduce the infection. But I want to add 2 more to this series. Number 1, in our patient, we have a heavy load of the patient. So our theater is running 20 hours out of 24 hours. We run 20 hours our theater, and in same theater we do the cranioplasty also in the morning. But what we do as a first case, second, it is always by senior. So this way we reduce our infection rate. Out of 64, only 1 patient we had an infection. So just want to add, do these 2 things. We do first case and by senior case per surgeon. So that will definitely improve the infection rate.
Thank you, Sinha sir. Professor Corrado. Professor Corrado, can you hear us?
Yes, thank you. I have a
yes, sir. So you have a question for Dr. Harry.
Yes, a question for Harry Me. First of all, nice to meet you. Finally, we meet.
Yes, nice to meet you. Hello, hi.
At least virtually. And this is a question that I talk also with Dr. Collias, Professor Hutchinson. Don't you think that it will be possible in a next very close future to product a document where we can propose a CRF case report form with a minimum requirement to suggest for the people, for the colleague who treat pathologies such as cranioplasty? I mean, some huge organization like Cambridge or some other university can, in your opinion, it will be possible that they product not only the analysis of the past, but only proposing analysis for the future? I mean, just to help people that want to analyze his work and to propose in a document, in a paper, in a publishing, that if you want to collect data for the future, use at least this minimum requirement to suggest to all the people that can make research also with low limited research. So the people maybe doesn't understand if I have to collect the outcome, in which case is important to collect measure hydrocephalus, or is important to collect frailty of the patient. I mean, a minimum requirement.
Yeah, I agree, and certainly that's what we should all be aiming for, not just for cranioplasty, for all health conditions, but relating to cranioplasty specifically, the cause is really just one part of a wider piece of work on what should be recorded as a minimum in clinical practice and research. The cause, yes, we're sort of leading the project, but it's very much a national and international project from both the steering committee and the participants who've scored it. And really the aim of that is to get a minimum set of outcomes, as I described, to what any researcher or clinician as a guide could and perhaps can measure. But I agree, as part of that, we should also do a common data element set, so a CDE, and have a position statement, not just from Cambridge, but from across the whole cranioplasty community on what we should be measuring from baseline characteristics through to outcome. The registry, I know there are a number of registries across the globe for cranioplasty. I think we should also look at trying to find a way of perhaps combining these. The German one I know is really fantastic, as and I know there are other ones as well. Our one is beginning. There have been difficulties in consistent data entries, but it is improving, and I hope that the core outcome set and the future CDE will just go to a way of helping to sort of standardize that process. But it's not a quick fix. It's not going to change overnight just from the core outcome set. But I agree with you. We should be looking at to do that.
Yes, it could be part of the project, could be another endpoint of the project. At the end of the project, if you want to study your cranioplasty patient for the future, you have to define minimum these data. In consensus
I agree.
conference, consensus conference on cranioplastic, I try to do this, for example, and we the statement where we define which means early cranioplastic, ultra early cranioplastic. So in the future, I hope that the people that wants to demonstrate the early cranioplastic works, they have to define early cranioplastic in that range of time.
Yes.
Okay. Thank you.
Yeah. No, I agree. I agree. Yeah.
Thank you. There's a question from Dr. Manoj Sivvi. He's asking that if the defect of craniectomy is large and having huge depth due to the sunken brain, in these cases, how we can prevent post-operative EDH formation other than by tenting sutures? I think maybe we can get an expert opinion from any of the authorities here. Dr. Corrado?
Can you repeat?
The question is, sir, if the defect of craniectomy is large and there is a huge sunken brain, in these conditions, if we are tacking sutures, but any other way we can prevent the post-operative EDH formation?
Nothing of evidence-based medicine, but I have some colleagues, for example, that leave the patient resting with the Trendelenburg position for the first days. The stitches on the dura is absolute an optional, absolute personal perspective. For example, I reduce the number of dura stitches for the suspension to avoid some danger up under the dura. So there is no any paper with evidence-based medicine about this problem, but talking with a lot of people, a lot of colleagues that treat cranioplastic, each of them has some personal solution. Of course, you have to pay attention about the hemostasis of the patient and the liquid, delivering of physiological solution, something like that. But there is any evidence-based medicine.
Dr. Sinha, can you give some opinion on that?
I don't think we do only the hemostasis. There is no other way. I think good hemostasis and stitches is only the final answer with us. What we do, I don't have. I think the position.
I see a lot of hematoma with the suspension stitch of dura. So I don't think that the stitches are a sure method to avoid the hematoma.
So one little trick that we've done sometimes, and it works sometimes, is to lay the patient on the side of the cranioplasty if they have this big sunken deficit, and that sometimes helps the brain sort of by gravity. And sometimes these patients will surprise you because they'll have a big sunken flap, but somehow when you make the cranium whole, it all works out. But on the other hand, we've seen big hematomas where we've had to go in and reoperate. So you never know. Obviously, if they have a shunt, then you know, in all patients that have a shunt, I dial up their shunt to the maximum level before the cranioplasty.
Yes, but sorry, Guy, a question for you, Guy. When you report the surgery for hematoma, you means that you operate all hematoma that you observed in postoperative CT scan, or just some hematoma? At that point, which is the inclusion criteria to operate a postoperative hematoma after cranioplasty?
You know, we absolutely do not operate on every hematoma. If we did that, we would have a very high reoperation rate, because I think it's very common to see a little bit of a skim hematoma under the bone flap or under the peak or whatever it is, and you just watch those and it'll get resorbed. But when the patient has a big epidural there and they've deteriorated neurologically, I mean, I think that's the key, just like in anything in neurosurgery. If they deteriorate neurologically, if they have a big hematoma with mass effect, you have to go in there and take it out. And it happens sometimes when they have these sunken flaps. The good thing, quote unquote, is you can usually take it out, meticulous hemostasis again, you know, do your best, and you can get the flap or the implant back on. I think one of the advantages that I found over the years with PEEK is that it comes with these holes in it, and so even if you have a little bit of bleeding underneath the flap, when you have the drain in to suction, you can usually take care of that. You know, I find that you get less problems after that. So that's an advantage. But these things can happen.
You use the drainage under suction or just in the fall? I mean, the drainage is just connected with a bag, or is connected with a suction bag?
No. If the drainage is over the implant or over the autologous bone, I think it doesn't do much of anything if it's just connected to a bag. We put it to suction. Now, sometimes I put the JP to full suction. Sometimes, for whatever reason, if I'm concerned, then I put it to half suction. When would I be concerned? You know, when someone's had bone resorption, for example, that bone, you know, when you try to separate it from the dura, you know, 6 months later, you'll have these invaginations of that pseudodura there, and you can get these very small tears that you won't even see during the surgery, but they'll develop a pseudomeningocele afterwards. And that can also be a tricky problem to get over, because they end up requiring lumbar drainage for a few days, and you have to sit them upright, they have to sleep upright. So sometimes I leave half suction at that point. But no, for it to be effective, I think you have to have a JP, you know, with one of those grenade suctions.
Because
yes,
if Virendra remember, we saw 6 months ago in another webinar about cranioplasty, the sudden death of a patient after cranioplastic, and the death was due to the over drainage,
yes.
suction drainage. Remember, Virendra?
Yeah, I remember.
It was amazing for me. I didn't know this option. Thank you.
So there was a question from Dr. Manoj to Dr. Jay Prashant, which has already answered on the chat box. It was regarding the meticulous hemostasis. So generally, he says that he uses fibrin glue along the extradural bone edges and has 2 suction drains under suction, one in the frontal and one in the parietal region, to prevent that. And so we are practicing the similar thing, but not that too much suction. We put in a drain, we leave it for 2 days. When we have, the sunken flap is a larger one, we put in 2 or 3 tacking sutures, and we usually increase the diameter of the holes through which we take the sutures. So it's like way to maybe like the peak, the blood can seep out, or it can be collected by the extradural drain. And it has seemed to have some better effects than the earlier, though it's not like recommended on any academic platform. But yes, it is a thing which we are practicing for a few days.
Yeah, I must say I routinely put 5 tacking sutures. So I haven't had Prof. Corrado's complication of catching anything too deep. I routinely put 5 tacking sutures. The reason I seal the epidural space with fibrin glue is because when you put the PEEK implant, if you sit it very well, it actually strips some of the soft tissue in the epidural space, which you may not realize causes bleeding. So I was at Karolinska. I learned that technique from Karolinska. And for us, cost is not that much of an issue because yes, tissue or fibrin glue is expensive, but the implant on its own is also very expensive. So we try and manage it that way.
So there's a comment from Dr. Hitesh Guja. He says that usually the brain comes back to the normal position after cranioplasty, which we all see. And yes, sir, we agree with that. But in some cases in which the flap is too much sunken, in those things, I think we can go for this stacking suture. So it has been a wonderful session and a very nice academic feast, and it has made the concepts of cranioplasty clearer and easy to understand for all the young neurosurgeons who are witnessing this webinar. And I thank all the speakers for the precious time. And I now hand over the platform to Professor V.D. Sinha for concluding and the vote of thanks.
Okay, so again, on behalf of Neurotrauma Committee AA-SNS, I thank all esteemed speakers, Dr. Corrado for coordinating this, for managing the speakers, Dr. Fontes, Dr. Jayaprashant, Dr. Harry, Dr. Rosenthal. And I think best part of this webinar was very good discussion, because this is a surgery which everybody do in this clinical life of as a neurosurgeon, and had a lot of problems. So I think everybody understand a lot from this webinar, and that will help in patient benefits. Thank you, everyone. Keep in touch. Thank you.
Thank you.